this symposium, and it's meant to be an event that brings patients, community together with Fred Hutch specialists for a conversation. In years past, this particular forum has been very, I would say, didactic. It's felt like school, a lot of slides, and we've heard feedback from the audience that maybe the best part of the day is the conversations we have. So we're trying to style it to be a little bit like that. Forgive us, it's a work in progress. So if it feels a little clunky at times, just go with the flow. My name is Yaw Nyame. I'm one of the urologic oncologists here. I'm a prostate cancer surgeon and also a researcher that does work with prostate cancer survivors, many of whom are in the room today. We have some rules and regulations, so I'm going to try to remember this. The event is being recorded. A link will be shared with everyone who has registered for the event, so keep an eye out for an email a few days after. There are virtual attendees. You guys can put questions in the chat as we go along. If you end up getting kicked out, you can rejoin by just clicking the link that you used to log in the beginning. For folks in the audience, we're going to be passing out note cards, index cards, like back in grade school, and those are meant for you to write questions down as we go along. I will collect those questions, and for each kind of section we have, we'll have a little Q&A that I will MC. So as we get started with our presentations, we'll make sure we start passing those out. Post-event, we would love your feedback. We do send a survey. Please take a couple of minutes to complete that so that we can make this event better for you next year. And then I would be remiss without pointing out that we've grown. We've grown in many ways. This was started really with grant funding from the Department of Defense. Now we have some sponsors and partners. So I want to point out that we have Lisa Hall from Zero here in the back. Thank you, Zero, for your partnership in this event. We're also supported by the Institute of Prostate Cancer Research. Really grateful to Dan Lin and Pete Nelson for their leadership. Many of us are members of IPCR, and they support the collaborations that we have as scientists and clinicians. Also want to thank Johnson & Johnson for sponsoring today's event. They're making food and meals possible. And then lastly, we have two very special supporters of the event. We have Intuitive, and we have Boston Scientific, who have brought some real equipment that we use in managing patients like you, for people in the audience to demo and see. You know, one of the things that I realize as a robotic surgeon is when I say robotic surgery, I can only imagine what's going on in a patient's head. Like, what does that mean, right? So today you'll get to sit down in the console, see what we see and feel what we feel or not feel when we're moving the instruments around. So we're really grateful for that. So I want to give a round of applause to all the people who support us today. All right, this is our agenda, just a light schedule. We'll try to be on time. And there will be opportunities for questions on breaks too. Many of our speakers will hang around for a little bit before they get back to watching college football and taking care of their families. So you'll have some opportunity to do that. Now, as we transition to our speaker, our keynote speaker, Dr. Buckley, I want to take a couple of minutes to introduce actually some very special speakers that are part of today's program. And I'm going to announce them, and I'm going to ask them to stand up as I talk about them. So David Anthony, if you could please. David was diagnosed in 2016 and underwent surgery in 2019. He had a recurrence 3 years later and was treated with salvage radiation and 2 years of hormone therapy and abiraterone. His paternal grandfather had cancer, and he's felt very motivated to work with us in BACPAC because of his journey and personal experience. He's married to a nurse anthropologist, recently retired history professor, emeritus professor. Congratulations. He has three adult children, a daughter and two sons, and 4 grandchildren. He belongs to 2 prostate cancer support groups and 2 clinically led research groups with us. He is a musician. We have many people who are musicians in the group. He plays saxophone, flute, and clarinet, bass clarinet. and he spent a lot of time in Africa as a researcher. We're really grateful to have you here today, David. All right, Grantley Martelly is a minister and owner of Shangi Services. Did I get that correct? All right. He's a strategy advisor consultant. In 2025, he started the Real Health Black Men podcast. It's an initiative that stems from his own personal battles with spinal stenosis and prostate cancer. And he felt there was a need for more awareness and education around health, in particular, health that affects men and Black men. He and his wife, Tahimina, founded Shanghai Global, a nonprofit organization that provides strategic, operational, and fundraising assistance to other nonprofits. They're both here today, and Grantley is going to be one of our speakers today as well. All right. Kojo Ward. Kojo describes himself as African, Ghanaian to be specific, in his mid-50s, who was diagnosed with cancer in his early 50s. He had prostate surgery and a recurrence requiring salvage radiation last year, and is finally feeling like he's getting back to his old self. In his free time, he takes care of a special needs son that he loves dearly. He didn't write that down, but I know that. And he enjoys biking, exercising, and being engaged with community. He's an avid Seahawks fan. Sorry, I'm rooting for Baker tomorrow. And a smooth jazz lover. Thank you for being here, Kojo. All right. Ken Hutchinson. Is Ken in the room? There he is. Kenny, how did I not see you, man? Ken is a 10-year survivor, passionate advocate of prostate cancer awareness and PSA screening for early detection. Ken seeks to bring awareness to all men, especially his African American brothers. Ken, thanks for being here. All right. Marty Chakoian. Marty, could you stand, please? Marty describes himself as an old man. Based off of the guys in his cycling group, he's a young man because he was kicking their tail. He has a history of prostate cancer, lives alone with his dog. He's been a leading prostate cancer support group here in Seattle for more than 10 years. Marty really is the glue in Seattle when it comes to support groups. He's been an advisor for BACPAC. He's been involved with our SPORE as a research advocate, and he's been on the board of directors for Zero. Marty is an incredible partner, and we're really grateful for him to be an ally and a friend in the work that we do. So Marty, thanks for being here today. All right. Patrick Bingham currently lives in Austin, Texas. Despite being a Longhorn, Patrick and I, we get along quite well. But next weekend in Dallas, when I see him, hopefully I'll be. You can't go. Oh man! All right. Well, the last couple of years we've been trying to catch each other I grew up in Oklahoma, so I'm a big Oklahoma Sooner fan. It's wonderful to have Patrick joining us from Austin today. He was diagnosed in 2005 after his 46th birthday. At that time, he did not know that he was at a higher risk for prostate cancer simply for being a Black male and also being a military veteran. So he has been cancer-free for over 15 years. And he's been a staunch member of our research team in our early detection program. Thank you for being a speaker today. All right, the only person to not email me, Bing. Now I just get to freestyle. Yeah. Bing and I grew up like a mile apart from one another. He grew up in Putnam City area of Oklahoma City. He's an Oklahoma native, as I just said, a graduate of the Naval Academy. And I think one of the most impressive things about Bing is how dedicated he has been to fighting for veterans across the country for many, many years. He has been a prostate cancer survivor, as he will say sometimes, times three, and is cancer-free to our knowledge and doing well. We're really grateful for you, for all the things that you do. Bing is now, he's become so enthralled in the healthcare space that he has an executive role for an emerging healthcare company. So he's very knowledgeable and brings a patient perspective and that of industry today. So with that, I'd like to give a round of applause to our advocates. They are going to be responsible for interviewing our health experts today. So we'll see how these conversations go. They're very chatty and they're very knowledgeable. So good luck to Dr. Darst and Dr. Calle down there. We've been training them. So with that, I want to transition to our keynote speaker, Dr. Buckley, who's the Vice President and Chief Workforce Experience Officer here at the Fred Hutch Cancer Center. His role is set to really help us as an institution in making sure that the Cancer Center's values and community values are embedded into all of the work that we do, both in our scientific endeavors and in our clinical mission. Dr. Buckley, it says Paul here, but I'm going to call him Dr. Buckley, works with a variety of internal and external stakeholders in support of the research and care mission. And I think I'd be remiss not to say this is a challenging time for healthcare institutions, for many communities. And I thought that in some private conversations I had with Dr. Buckley, that his outlook on where this institution can and should go with the support of people like him was really uplifting. So I'm very happy to call Dr. Buckley a friend and even happier to have him here today to be our keynote speaker. So please give him a warm welcome.
Good morning. Please forgive me. I have something that happens this time of year. I'm always working through the throat. But it is so good to be here with all of you. I feel very honored to be in your company, champions, survivors, advocates, brothers and sisters, people, community. And I love the fact that when Dr. Nyame offered this invitation, it was both very thoughtful and really warm, really, really warm. And so I'm grateful to be able to be here in support of him, in support of the work, and to share company with you. I want to keep the spirit of how this session was convened, even as I offer these remarks. So I'm hoping that you'll be willing to be in conversation with me throughout my sharing of reflections. Dr. Nyame offered a choice of slides or no slides, and I decided no slides. Let's be in, I'd rather not have a presentation, but really to have a conversation with you. I may or may not put on these glasses. This is a new thing for me over the last 5 years. I'm still resisting it. I'm like, why do I have to wear glasses? It's something my mom and father used to do. It's not something I see myself. I'm having an identity crisis, in other words. So just work with me. Dr. Nyame, it seemed like it was a long time ago, a few months ago, that you offered this invitation, and somehow the day has arrived. And I'm also feeling some gratitude about that because it means time is moving fast. And I need time to move fast this year and fast for the next 3 years. And let it be 3, please, tops. Okay, so I might, in my conversation with you, because I am a man of faith, I might call upon my Lord and Savior a few times as I look at and share about some of the things that I see, which are, in fact, quite terrifying. So I do want to be in conversation with you, and before I do, maybe I'll share a little bit of my story, how I got to Fred Hutch. So I first want to note being the son of immigrants who've been naturalized in the United States. I want to acknowledge with gratitude the great parenting that I had, the commitment to progress and support and community. Education was critical in my home, that there were 2 jobs happening in the house. My parents went to work and they saw it as the job of their children to go to school and perform well. And we were reminded often, I go to work, what did you do today? I bought your food, how did you perform on that test, right? And my entire education up until the doctoral program was a public education, which I'm also grateful for. Went to public schools, had great teachers who cared and who taught and who expected me to rise to high expectations. They did not have low expectations of me or any other student in their classes, most of my teachers. So it was almost natural that I found myself in education, in higher education, and had a long and impactful career in higher education before transitioning to Fred Hutch. And how I got to Fred Hutch takes me back to the fall of 2018. I lost 2 dear friends and brothers to cancer in the space of a month, November 2018. And about a month and a half later, my dad was diagnosed with esophageal cancer. Up until his diagnosis in my family, cancer was not known to us as an experience within the family. We believe that my dad's diagnosis is tied to his response as a train conductor at the time in New York City in September 11th of 2001. Right? And so there was his diagnosis. We're in now 2019. And I reflect on those 2 losses and my dad's diagnosis, which primed me to see an opportunity in the Chronicle of Higher Education at Fred Hutch. I had not heard of Fred Hutch before. I'm a New Yorker. So whatever that means for your teams, you know, New York is number 1, but I live here. Come on now. I knew MSK, Dana-Farber, I knew East Coast cancer centers, but really did not hear about Fred Hutch. But I was drawn to the opportunity that was presented in the Chronicle of Higher Education, summer of 2019. Immediately, I applied within the hour, and I knew it was my next step. So went through the interview process. It was then Director of Diversity and Inclusion. I went through a rigorous interview process. White House, pay attention. Rigorous, rigorous interview process, and found myself here by mid-February 2020. And I have a knack for transitioning roles at very interesting times. My last institution, I started there 2014. I remember the first week of my work, the students protested through the streets of Colorado Springs, which had not happened ever in their history before. Michael Brown, kneel down for Michael Brown, and the earlier parts of BLM was happening at that time. So I get here in February of 2020. 2 weeks later, we are shutting down, right, for the pandemic. And you know about the heat, the social heat of the summer of 2020 and beyond. So I share all of that. That is my transition to Fred Hutch. Thankfully, we enjoyed 3 more years of my father's life. He lived in Florida. I was able to get through pandemic and then spend quite a bit of time back and forth with him before he transitioned. So I share that to say, that's a little bit of my story, but this is not, this work, professional work that I do at this time in this space for this institution, and in this broad work of cancer research and treatment, and all of us who support that work is deeply, deeply, deeply personal. And I'm grateful that I can wake up every day with a sense of purpose about where I'm going and what I need to do in support of incredible researchers and physicians like Dr. Nyame. So we're here at BACPAC, and I want to reflect on just a few themes, and again, be in conversation with you, and then really look forward to a robust discussion. So I reflected on 2020, getting here in spring of 2020, outlining a strategy for our then formalized diversity, equity, and inclusion program pre the heat of the summer. And that matters in terms of Fred Hutch's recognition of the opportunity to do deeper, important work, right? But we really, as a society, were in the kind of thinking that this was going to be a moment that would change our nation positively forever, right? That was a lot of people's thinking, that somehow the discourse, the discussion, the dialogue, the movements were repositioned for a deeper examination of what it means for us to be a democracy, a society that cares for each other, and that would make wrongs right, and repair harms. Thank you so much. Appreciate you. He's a New Yorker. She said was, but I know it means is. You know, you can't, New Yorkers don't ever not be New Yorkers. It's true. It's true. I haven't figured out, I hadn't figured out how much of a New Yorker I was until I left New York. And people try to say I was from somewhere else. And those are like fighting words in New York. Um, so we thought we were ready for repair, right? And one of the principles of restorative justice work and movements is starting with repair, then there's restoration, then there's reconciliation and reintegration when there's harm that has been committed in any context. But then we get stuck. We got stuck in just the recognition of repair, the recognition of the need for repair. That we are challenged as a society. Historically, we've been, and presently we are. Excuse me. Just really challenged to sort of confess our wrongs, right? To be honest about our wrongs. And we struggle in that first step of acknowledging. We get stuck there, and then there is a sort of return to willful amnesia and and then a struggle to not move forward, but just to maintain the position of progress where we were and not go back. This is the deep, deep struggle we have as a collective in the United States of America. It's not one person's problem. It's not one group's problem. It's not one community's problem. It's not one institution's problem. It is our shared problem. And it matters to how we are able to live our lives in the present and how we can even imagine what this and the next generation can achieve together. As the father of 4 young children, I struggle personally when I get to the thinking around, well, what does this mean for them, right? I can kind of navigate. I have some sense of what I might be able to do, but then I get stuck. What does this mean for them? Repair, restore, reconcile, reintegrate. Dante, it's good to see you. You may remember that in 2020, 21, in some of our discussions, the caucus, I shared that then I was thinking about 2030. With what was happening then, I was wondering what was going to happen by 2030. And even with that foresight, I didn't imagine 2025, right? I didn't imagine so quickly, so harshly, so cruelly, and how difficult it is at the present. Seeking restoration usually requires some kind of direct communication between victims and offenders. And this is what makes language an important site of conflict, and why it is important to give attention to the discourses that emerge, change, and shift in various levels of dominance. The power of discourse, which is where I really want to focus a lot of our discussion, the power of discourse cannot be overstated in this era of confusion and desensitization toward the inherent value of human life and the reverence of truth. As we talk about discourses here, I do not mean just conversation or words, but more so, based on my doctoral studies, I'm a fan of Foucault. Some of you may know that French philosopher. He has a lot to share with us to inform us about how discourses work. And discourses, as Foucault puts it, really are about systems and structures of language. It's really about systems, structures of language, and how those systems and structures of language discipline our ability and how we speak. Discourse theory defines discourse as a system of statements, ideas, beliefs, and practices that within a specific historical context systematically shape how we understand and produce knowledge, objects, and subjects. So there's the scholarly understanding of discourse and discourse theory, but then just as a human being with a deep understanding of the power of discourse, I remain absolutely terrified by what I observe in the shifting discourse of our present day. Let me give you a couple of examples of the discourses that we are navigating. There's the discourse of DEI mediocrity, right? Which is synchronous with the most unqualified administration in history, right? That's a part of how discourses work. And I'm going to give you a couple of other examples, and I want us to really think about them because we observe them, but we're challenged to really make sense of them or disrupt them. There's the discourse of crime and disorder, while the proclaimer is in fact a convicted felon, right? On 34 counts, 34 counts. Or the discourse of science manipulation that leads people to deny the efficacy of vaccines or influences patients to not talk with their doctors, but actually be confused about what to do about their own health. That's how powerful discourses are. It is literally shaping one's understanding of themselves and reality. So it's important to understand that the power of discourse is diffuse. We're not talking about one individual. There are many actors, and avenues within social spaces where discourses has the power for restructuring our social spaces. It isn't only about the idea that there are words we cannot say, it is that they are words that describe our reality. They are words that describe our experience. And so a fabrication becomes something that is actually generated, right? So there's a generated notion of reality that becomes reality when the dominant discourse denies the reality you and I know. Make sense? All right. Discourses create a world in which we are less capable of recognizing our acceptance of horrific violence. Whether we're talking about hundreds of thousands of lives, and I need my glasses now, or we're talking about 4 to 11 people on a boat that may have had drugs on it. The discourse of the drug boat restricts our outrage against inhumanity, right, to a tolerant silence. All this while some believe the administration is close to God or that the administration is a divine providence. I mean, there is a faith office, right? And there is this idea that the government is protecting life. So what we saw this week with Pope Leo XIV challenging the idea of pro-life, and this is not about where you stand on that, but the idea that Pope Leo challenges pro-life politics that also supports capital punishment or the death penalty is a very important opportunity in a shifting discourse because of who he represents, right? We can hear this symbol, this religious symbolic person with significant global power challenge this idea of whose life matters and how do we think about the value of life. So Foucault, in examining and presenting this theory of discourse, really began with medical examples, by the way, and helped us to see the discourse of doctors, and in contrast to patients and how power is maintained. And there's important work still to do in healthcare to empower patients in care and healing. All right. Okay, I have just a few, okay. 15, and I know we're supposed to get to discussion. So let me just transition from there to say, we have an opportunity here to generate or regenerate the discourse of scientific usefulness and responsible science. We have the opportunity to generate research rigor offering truth, right? The discourses of shared humanity, we the people, the Good Samaritan, etc. Those discourses we can be intentional about, as we've learned to do with our messaging, and we've learned to do with creating context in which people can be empowered to push against abuse of power. And the BACPAC is such a space, right? That it empowers all of us in this community to understand shared truths of how the science is working, of how your experiences as subjects within the social context can navigate medicine, can navigate relationships with health, with the healthcare system and healthcare professionals. But we must recognize how discourses operate on us, that they literally shape our meaning. And with that understanding, that it is critical to push back. So, healing. Harriet Washington, author of the difficult, truth-telling, and necessary for holistic health and liberation book, Medical Apartheid, conceives of healing as a multifaceted process that involves, one, addressing historical trauma, confronting the dark history of centuries of systemic medical experimentation and abuse of Black people in America. Two, systemic medical racism, the many ways medicine as a field and practice positions and treats Black people. And I missed my page here. Lost one of my papers here. Okay, and the work that we have to do to rebuild trust with communities as a critical part of the process of healing. We won't be able to heal as a destination without engaging healing practices. BACPAC does this. We need other contexts to do the same. And we need to recognize the power that we have in every context to require or demand that our nation responds to the needs that we have as the people. There is no government without the people. And a government cannot consider itself at any level of good quality without responding to those it claims to govern. So, whatever your context, beyond the BACPAC, in families, in communities, in groups, at work, I'm calling us to recognize the charge that we're given in this present moment, which is to claim our realities, to name them, and to require a response from our neighbors and our governments in order to seek truth, reconciliation, and, in fact, healing. Those are my comments this morning, and I look forward to your questions. Oh, sorry. Oh, yeah.
I'll moderate.
Do you want me to sit?
Please, yeah, we can give you a microphone. There's some handheld ones too, if you want that.
Yeah, I'll do this.
Okay. All right. So first question is there ever a time in history where we see discourse breaking things that cannot be restored? What does that say about things, structures, and truth being broken now that cannot be rebuilt?
Well, as Foucault puts it, and I agree that the thing about discourse is that they shift. And yes, they do break things. But as long as we're here, everything can be restored. Some will take much longer, right, than we care to admit. Like many of the things that have already been broken this year will not be restored in 3 years. And, that's a hard truth. If the breaking stops now, we still have decades to rebuild, right? But we must pursue that rebuilding. I mean, I think it's as fundamental a human right and responsibility to seek freedom as it is to repair. That is necessary. As long as we're here, we have to repair.
I have a question for you, Paul.
Yeah.
What do you see our institution doing to heal the wide catchment area that is our catchment, right? Mm-hmm. Washington State, maybe Alaska, to make sure that we reach people wherever they may be. Mm-hmm. And certainly those who don't routinely access Fred Hutch for care.
Yeah. I think, you and I know we've been in the room for discussions and a vision around that for Fred Hutch to be expansively accessible and to pursue that in a number of ways, right? There's community outreach engagement. There's our partnerships with clinical sites, our relationships with others across that catchment area. But it really is going to be incumbent on us to ensure we do not lose energy around that vision, right? In these very, very difficult times, very uncertain times, but we have to be clear about our commitments. And as I often share with people around commitments, our commitments are only as good as our next decision, right? And so we just have to be really clear that health and healing as a priority and mission for us means that we continue to push forward and we find new innovative ways to do so.
I have a follow-up question from the audience. Says, thank you for your civics lesson on healing and holding leaders accountable.
Yeah.
This is a question I think is meant at a broader scale, but I want to focus it maybe in the role that you have as a leader here.
Okay.
What do people in community do to have leadership listen to them, especially if they aren't viewed as their constituents or patients?
So, there is this idea of somehow the constituency here is not connected to the constituency over here, right? And discourse has shaped that as well, that understanding, which is just simply not true. I think that there can be particular experiences in any given geographical area or at any given institution, but there are always connections in experiences that are generalizable that we should learn from, right? So certainly, even in healthcare, we learn from various studies that may not have happened here, right? We learn from them, and we might, with our understanding, determine how we might tweak a response, but we learn from them. So I think making that clear to leaders that they are responsible to us, right? If you're not the leader, they're responsible to us. Leaders are responsible to us if they are leaders. And I think ensuring that we have an audience with them to be heard, staying on message, reinforcing the message, getting some allies to reinforce the message that we're trying to give to leaders is all a part of the strategy of having leaders hear us. Or we find ways to remove that leadership, right? And ensure that it can be replaced with better leadership, which is always a part of the challenge that we have, right? Is if you cannot work with who's there, who will replace that person and ensure that they are people you can work with? So I think all of those options have to be part of what we imagine and are willing to act on, and that we make clear to leadership so that they do not think that they are somehow indispensable and that their leadership can be abused casually, right? Which is how a lot of leaders think, right? They think of their position as permanent. They don't think about the relationality of leadership to constituency or followership. And then it becomes an abusive kind of leadership, right? Because they are just doing what they want to do, not being responsive to those they're responsible to care for.
All right. Well, Paul, thank you so much. A round of applause for Dr. Buckley. As you describe that kind of leadership, it makes me think of a term that I've heard more and more recently, which is servant leadership. And I think leaders that really believe in a strategy of servant leadership seem to run successful organizations, and something to that. Now we got to transition to prostate cancer. I'd like to welcome Dr. Darst to the stage. Dr. Darst is an assistant professor in the Public Health Sciences Division here at Fred Hutch. Burcu, who do we have you paired with? David Anthony. You guys can have a seat. We'll give you microphones to hold. Do you have slides for us? All right, look at that. All right. So I'll advance your slides for you.
I don't have too much.
Do you want to? My thought was I'd have David Anthony maybe ask you a question, start some conversation. As we go through each of these topics, please make sure to jot down your questions if you have them. And we will have a Q&A session after each block of speakers. So, David Anthony, I turn things over to you, perhaps.
Give me a moment. Transition, that was amazing. Of course, I would come to expect that from a New Yorker. Even though I've been living in exile for decades. Let me say one thing about glasses. If you have to wear them, you get the hippest pair that you can get. But these are my Malcolm glasses now. And I have about 6 pairs of glasses. 2 computer glasses, 2 shades, and 2 all-purpose. These are the Malcolm glasses. I have to say, I never thought I would be coming to a prostate cancer symposium and start off with Foucault. Man, you know, for a historian, you know, particularly a historian of Africa and the diaspora, that's heaven. You know, I'm done. I don't even have anything to say now. It was so good. Would you like to start by saying anything?
I can maybe just introduce myself to give that little background. So my name is Burcu Darst. I'm a faculty member here at Fred Hutch, and I'm a genetic epidemiologist. I was hired here on a cancer health disparities position. So my research really focuses predominantly on understanding prostate cancer risk factors in prostate cancer patients, particularly Black patients, because we know that Black men have by far the highest incidence and mortality rates from prostate cancer. So we really want to identify genetic risk factors that could be helpful to these men who are faced by the highest burden of prostate cancer. And yeah, that's my kind of general intro. But yes, I really focus on trying to understand inherited genetic risk factors that are passed down from families to offspring.
Okay. What is the biggest or most exciting advance around prostate cancer research in your estimation in the past year or past few years?
Yeah. So in the past few years, there have been really huge improvements in technology that have made it much more, can you guys hear me? I know that my voice is kind of low. I want to make sure everyone hears. Okay. That have made it really measure, like it turned off now.
We have another mic.
Oh, maybe that's better. Okay. Sorry, this is okay. That have made it possible to measure the genome, the inherited genome, much more accurately and efficiently and more cost effectively than it has been before. And because of this, we have these really large scale genetic, huge numbers of participants. Sorry, it keeps going out.
We can get you another mic.
Okay. Okay. Is that working? Okay. Thank you. But because of having these really big numbers, we've been able to identify genetic factors that we didn't know of before that are really important risk factors for prostate cancer and could really be informative to help people decide, should I get screened for prostate cancer and what age should I start doing that? And I have some examples of this that I could talk about if you'd like to hear about some of them in particular.
I'm putting them up.
Okay, great. So the first one that I'll talk about is a variant in this gene called HOXB13. And I have these notes here because there's a few numbers and it's always hard for me to remember them all. But there's this one particular variant in HOXB13 that's only found in populations that have some African ancestry. So this is a genetic risk factor, a very big genetic risk factor for prostate cancer that's only found in African ancestry individuals, which is kind of it's sort of promising in some ways because it kind of says that there's this risk factors that if we know about it ahead of time, we can help guide your treatment and your screening decisions because of this risk factor. So this one in particular, this variant, there's a lot of names here that you don't necessarily need to know, but it's just a way to refer to it. This variant called X285K in the HOXB13 gene, it's very rare. It's only found maybe in 1 in every 300 people who have some West African ancestry. It's actually specific to West African ancestry. But if you carry one or more copies of this really rare variant, you have 2.5 times higher risk of developing prostate cancer, and you have about 5 times higher risk of developing metastatic or lethal prostate cancer, which is a really big risk factor. And one thing I also want to address, because people ask this question sometimes, I'll be talking about genetic variants. Sometimes people say, what is a genetic variant? So most of our genome, about 99% of it, is exactly the same from one person to another. There are a few spots in the genome that differ between people. And when you find a spot that's different from one person to another, we call it a variant. Sometimes these variants, usually they're harmless, they don't mean anything, but sometimes it might increase risk for something or make you more likely to have one trait versus another. In this case, this one is a big risk factor for prostate cancer. So that's a really good one to know. And then if you go to the next one, yeah.
I know thanks to Ancestry.com, it's estimates that I have not only British Isles, of course, but West African and Central African ancestry. How could I determine, or how could one determine whether or not this gene is part of that mix?
So we do know that that particular variant is more common in people who have more West African ancestry, but you would have to get tested like explicitly for that particular variant because it's very rare. So even if you have a lot of West African ancestry, maybe you're more likely to carry it, but it's still only 1 in 300 people. So it's really rare. So you would have to get tested explicitly for it. Other thing I'll mention that's really promising about this variant is that it's now in the national guidelines for early detection of prostate cancer. If you know that you carry that variant, then they recommend that you start getting screened at an earlier age. But I'm not really sure what companies you would actually go to, or if you can just ask your doctor, like, can I get tested for this? I think those things, even though it's in the guidelines, I don't know if maybe any of the urologists know how you actually get tested for this particular variant, but I'm not sure what companies are currently offering things like this.
I mean, I'll just say to my knowledge, there's no commercial platform that's routinely screening for these. This is part of what we've been talking about in some BACPAC work with Isla Garraway, wanting to explore further how we can maybe make this a little bit more routine. But this is certainly very exciting research.
And then I can go through it, just a couple other quick examples. So there's another variant in this part of the region of the genome that we refer to as 8q24. That just means it's on chromosome 8 and it's the 24th position, but we just refer to it as 8q24. This one is actually pretty common. It's found in 1 in 10 people who have some African ancestry. And this one is not really specific to any region of Africa or of African ancestry. It's actually found in individuals across the continent of Africa. And the frequencies don't really seem to follow any pattern. It's just more common in those who have any African ancestry. And this one is also a very big risk factor. If you carry one copy of it, if you click on the next tab, you carry one copy of it, you have about 2 times higher odds of prostate cancer and about 2.5 times higher odds of lethal prostate cancer. If you carry 2 copies, that goes up to about 5 times higher odds of developing prostate cancer and about 8 times higher odds of developing a lethal prostate cancer. So it's another big risk factor. And then the last one, if you go to the next one, and you can click again. Okay. The last one I'll talk about is a polygenic risk score, because this is kind of a hot topic right now. So the other 2 examples I gave were for very specific single genetic variants, but there are variants across the genome that are really big, that are strongly associated with prostate cancer, but on their own, they contribute maybe a very, very tiny amount of risk. But if you aggregate them into one score, that can kind of summarize what is your risk of prostate cancer. And in aggregate, as a single score, it's a really big predictor of prostate cancer. So here, if you compare men of African ancestry in the highest PRS category, the 90 to 100% PRS category, to those in the average category, those men in the high category will have about 3 times higher odds of developing prostate cancer and about 4 times higher odds of developing a lethal prostate cancer. So this is another example of something we've learned in recent years from having these new technologies that could really inform who's a good candidate for screening and when should you start screening for this.
Minutes, maybe one more question.
Okay.
You want to ask David a question from your perspective?
Yeah. Can you, yeah.
Sorry.
So, I guess I wanted to ask just what are your experiences as a patient and as a patient advocate who's been involved in this for a long time with genetic testing?
Well, I don't have a personal experience with genetic testing yet, which is why I'm extremely interested in this topic because, I already had a genetic predisposition of which I was only dimly aware until I started to think not only of my paternal grandfather, but the fact that my father died of cancer, not prostate cancer, a different cancer. It was lung cancer that had metastasized to his liver. My maternal grandmother died of pancreatic cancer. So I was actually living in a cancer cluster in my household. And I still have not been tested genetically. I've gone through these experiences, of the manifestation of cancer and a recurrence, and I still haven't had that. And I've got 2 sons and a daughter. So, I certainly want to have them aware of and to go through screening. But I'd also like to have some screening myself, even after the fact. I think it's still important. And this, what you have indicated here, I know I have West African ancestry. I know I have Central African ancestry. I know I've got across the board Africans as well as Europeans, and I think it's really time for me to gain some information about that.
Yeah.
Before my transition.
Yeah. The other important thing about genetics is that now we have good information that men who carry certain genetic risk factors respond better to certain treatments. So if you have a really advanced prostate cancer, like one that has spread outside the prostate, it's recommended to receive germline genetic testing, inherited genetic testing, to see if you might carry one of these variants that could lead you to respond better to certain treatments. And I think that's something that a lot of patients might not be aware of. In the state of Washington, among patients who are eligible for that testing, only 10% of them undergo genetic testing.
Yeah.
And it should be, maybe the urologist can correct me, but it should be free because it should be covered by insurance.
A little bit
Because it's in the
complicated.
guidelines.
It
but
is in the
only-
guidelines. It is complicated. We're lucky, right? We have a great genetics clinic. If I have, I do have patients in the room, if you have a family history like David's, I would offer you that referral to see a counselor. Sometimes to me, it's a slam dunk. I hear, oh, so-and-so in the family had a cancer. You are a cancer patient. And I put in the referral and they don't quite meet the criteria of the NCCN. So that does matter, what degree of family, what types of cancers, but for you, I presume based off of your treatment, a high-risk patient, you would definitely qualify, and you still do. So I think you could get genetic testing, David, as part of your treatment. If you have questions about genetics, we're going to have a Q&A session. I see hands go up. Get your index card, write them down. We got dedicated time for that. We're going to move to our next topic, which is around screening and biopsy with Dr. Calle, who... I have a schedule that doesn't have our patient advocate listed on it, and somehow my brain is not functioning. Grantley Martelly, is that correct? Grantley, come on down. David, thank you. Hi. All right. A quick introduction of Dr. Calle. She is an assistant professor of urology at UW Fred Hutch. Dr. Calle is one of our newest additions to our prostate cancer team. She's an incredible partner and a friend. And I'm really excited that she's sharing her expertise with us here today. So similar format. Again, we're trying this new conversational style. So it'll start with Grantley asking a question. Hopefully we can get the mics working. Is yours on? Good. Grantley.
Good morning.
Yes, good.
Dr. Lakai, it's good to meet you, and it's good to
Nice
be
meeting you as well. Good morning, everyone.
a part of this discussion. Today, we're going to be talking about, I think we're going to be talking about screening and biopsies.
Yeah.
So one of the things that I hear pretty often as part of our Black men support group and from people that I interview on my podcast and talk to is when is the appropriate time in your diagnosis to have a biopsy? There seem to be some discourse around, should it be immediately after high PSA or should it be after the MRI, or when is the appropriate time, and also where? Sometimes they say, should it be in the doctor's office or hospital?
Yeah, great question. So first of all, our guidelines say that if you have an elevated PSA, the first step is to repeat that PSA. In 20 to 40% of cases, the PSA will go back down. And I always like telling my patients, PSA naturally yo-yos up and down. If you were to check it every day, it would never be the same number. And it's a function of how much inflammation is going on essentially in the prostate. So very, very important to repeat it. A high PSA is not necessarily alarming as long as it goes back to its original baseline value. Then assuming we repeat it and it's still elevated, then what do we do? Do we jump straight to biopsy? Oh, and now that Dr. Nyame is back, I'll ask to go to, I think, the next slide after that. Yeah, we're talking about, what to do if the PSA is elevated. And one of the major concerns with prostate cancer screening is overdiagnosis and overtreatment. And so I think it's very important to use what we call adjunct testing. So another test, essentially, before going straight to prostate biopsy, to make sure that a prostate biopsy is really indicated. Because when we do a prostate biopsy, we want to do it if we really think there's a good risk, a good chance that the patient might have high-risk prostate cancer. Many men walking around Seattle have low-grade prostate cancer and never know about it, and that's okay because these are very slow-growing cancers that in the majority of cases will just be in the prostate forever and never really cause issues. Those tend to not be cancers we really need to know about. And of course, there are men that have high PSA for other reasons unrelated to cancer, and so they would get a negative biopsy. So we want to try to limit the biopsies where we're finding no cancer or very small amounts of low-grade cancer. So my personal favorite adjunct test after high PSA is an MRI of the prostate. So that's the first option I put here. MRI of the prostate is an imaging study that gives a lot of very valuable information. First of all, it gives us an accurate size of the prostate. And so that helps me calculate PSA density. So it's basically the PSA divided by your prostate volume. If you have a PSA that's mildly elevated, but then we find out that you have a huge prostate, then that PSA suddenly doesn't feel that high anymore, right? You can think, okay, probably the PSA is high because the prostate is enlarged. Secondly, the radiologist will look for lesions in the prostate that could be concerning for prostate cancer. And they give a score to that lesion on a scale from 1 to 5, 5 being the worst. And that really gives me tremendous risk stratification and helps me counsel the patient on the need for prostate biopsy because I can give them the numbers. What are the chances of them having high-grade prostate cancer based on the score that their lesion got? So for example, if they get a score of 1 or 2, which is usually considered negative, the risk of having a high-grade prostate cancer is going to be less than 5%, pretty low. But on the other side of the spectrum, if they have a score of 5, so the highest score.
Is that a Gleason score you're talking about?
That's the PIRAD score, just to make it more complicated. These are scores just based on the MRI. And if the PIRAT score is 5, then suddenly the risk of high-grade prostate cancer is in some studies as high as 70%. So you go from less than 5% to 70. So that huge change can really help, with patient counseling. Then, well, another question you might ask next is about other tests like liquid biomarkers.
Yeah, so we wanted to talk a little bit about that, but before you go there, just quickly for the new people here who may not know what a biopsy is, maybe give a short description of what happens during the biopsy.
Talk about the biopsy next. Yeah, of course. So assuming we did all of our due diligence, adjunct testing, we think the risk of high-grade prostate cancer is high enough that we should proceed with a biopsy. Then there are multiple ways to do the biopsy. The most commonly performed biopsy in the United States, about 80% of biopsies are done this way, is through the rectum. So there's a little drawing here. You can see that that's the bottom needle. So it's going through the rectum and into the prostate. So there's an ultrasound probe placed in the rectum. That's how the urologist can see the prostate. And then the needles go through the rectal wall and into the prostate. The rectum is a great way to access the prostate. As you can see, the prostate is right in front, right on top of the rectum. And then if there's a lesion, so a potential tumor noted on MRI, so in the example I gave, there's a big dark area where the arrow is at the top of the prostate there. We can do what we call a fusion biopsy, where basically we fuse the MRI images with the ultrasound images, and the MRI essentially guides the urologist during the biopsy. So that's one way to do the biopsy. And another way to do the biopsy is through the perineum. So that's the top needle on that little drawing. So here, the needle goes through the skin that men have in between the anus and the scrotum. There's still usually an ultrasound probe placed in the rectum to see the prostate, but the needles go from higher up, essentially. And about 20% of prostate biopsies in the United States are performed this way. And I have a little more in the biopsy if you're curious. Yeah. So sometimes people ask me, well, what type of biopsy should I have? There are some advantages and disadvantages to both approaches. And the first thing is that biopsies, sometimes are urgent and really need to be done. And if, where you live, the only type of biopsy you can get is the transrectal, then I highly recommend it, because if a biopsy is needed, then, it needs to be done. Advantages of the transrectal approach is that studies show that it is faster. It takes on average 8 minutes versus 15 minutes for a transperineal prostate biopsy. And studies do tend to consistently show that the pain scores patient report during transrectal biopsies are slightly lower. So maybe a little slightly less painful. There are disadvantages to this approach, though. You have to take very strong antibiotics for the procedure, because since you're going through the rectum, you could insert bacteria from the stool into the prostate. And then there are some tumors that can be hard to access. I think maybe there's like a little animation there. Maybe click one more time. Yeah, thank you so much. So the tumors that are at the top of the prostate, we call them anterior tumors. Those are really much harder to access through the rectum because it's the furthest, away from where the needles are coming from. Whereas with the transperineal biopsy, if you click one more time, Dr. Nyame, thank you, you can see that the needles are coming from high up. And so it's easier to access those anterior tumors.
Okay.
On the flip side, the lesions that are at the base of the prostate, so those are the furthest away from the skin, the perineum, those can be harder to access with a transperineal prostate biopsy. Okay.
Yeah, thank you very much. Thanks for explaining that. My next question is, there's some tests coming on the market now. There's the MyPSA score 2.0, and there's some other blood tests coming on the market that are attached to biomarkers that lend some help to maybe helping with that diagnosis, screening, and maybe reduce biopsies.
Last slide. Yes, exactly. So
you see those helping in the process.
Yeah, these can be very helpful. So those are the liquid biomarkers that I put. There are many different types of liquid biomarkers on the market. And so I put a few examples of some, including the MyProstate score. The reality is that we really haven't compared any of these biomarkers head to head, so I can't really comment on which one is better than the other. But our guidelines do state that in situations where we're not sure, we need more information, we're still unclear, maybe even after an MRI, if we should proceed with prostate biopsy. I find these helpful because they can give us additional risk stratification. Or in a situation where you've already had a biopsy, it was negative, yet the PSA is still rising. We're wondering what's going on here. In that situation, they can be helpful as well.
So, yeah, so just finally, just to make sure that most of those tests have to be required by a doctor, so they're
That's right.
not like ordering off of Amazon, right?
No.
Or you get-
Unfortunately, it doesn't work. So but I have a lot of patients that are very proactive, and they actually they send me the link of the company they want to use, and then I put the order in for them. So yeah, but unfortunately, they all still require an order by a physician, yeah.
Thank you.
Mhm.
We want to maybe transition to Q&A, or do you have another question?
No, I just want to share a little bit about my experience. In my experience with a biopsy, I hear a lot of men talk about it was painful or not painful. Mine was more uncomfortable than painful. I had it in my doctor's office at Valley Medical.
Yeah.
And I think my wife was more uncomfortable with the conversation that the doctor was carrying on rather than me having the procedure. So mine was mostly uncomfortable and not painful, but I've heard many men say that it was one of the most painful experiences that they had.
Yeah. Yeah, the procedure, I certainly have patients that mentioned that it can be a very painful procedure. I think what's important to keep in mind is that an ultrasound probe is placed in the rectum. And so for some patients, that is the most painful part of the procedure, more so than the actual needles, because if the block is done well, the prostate should be numb. And so occasionally I have patients where I do have to do the biopsy in the operating room with anesthesia. Of course, continuous feedback, between the patient and the provider. I tend to ask, 20 times, everything okay? At any point, we can always stop the procedure and transition to doing it with more anesthesia. Yeah.
Yeah.
Thank you.
Well, Grantley, thank you for making that point, because our group met in August and we were talking about biopsy. And yes, one gentleman in the room said basically the worst thing he's been through. And then we had a corollary, which was like most strange thing I've been through, but not necessarily painful, right? Like, so your biopsy shouldn't hurt. Okay. All right. I'm just saying, like, not in that way, right?
Biopsy?
Not in that way. It should not like I felt like I needed a bite stick or like I wanted to be put out,
Yeah.
right?
It should
Uncomfortable,
not be
yeah.
traumatizing.
Weird, yes, maybe, but like excruciating pain, that's an important message to
You
get
can
out.
see this is a sensitive topic.
Yeah. All right. That does burn. We're actually doing a very interesting study on this.
We are.
Some results to report in next year around a better way to make that lidocaine not burn so much. We have a fellow who's doing a clinical trial. If any of you had a biopsy recently with us, might have been randomized in that. David?
I think this is a really important point, because those two positions are really dramatically different.
Yes.
I vividly remember my biopsy. I do not remember pain. But there are a lot of people who associate this with trauma.
Yes. And that shouldn't be the case.
And we've talked about this. I mean, we're working towards doing this large screening trial. And one of the things that I've put in the proposal for that feedback from this audience is that we need to understand better what the patient experience is around screening and biopsy. And we can measure things like pain, trauma experience, so that we can guide patients better. All right, Q&A time. If you have passed your cards, if you can pass your cards to the folks in the aisle, I'll start asking some questions. This one I'm gonna take to both Dr. Darst and Dr. Calle. Are there any efforts to establish a national age or genetic standard for testing PSA in high-risk populations like Black men?
Oh, sorry.
So the Prostate Cancer Foundation, I'm pretty sure Yaw was involved in this effort, right? You all recently came up with recommendations after carefully reviewing the literature to come up with a better recommendation for what is the best age to start screening for Black men. And they concluded that between the ages of 40 and 45 is the best time to start screening for prostate cancer in Black men.
I will say, just as a follow-up, that different guideline making bodies use different information to generate the guidelines. So for the Prostate Cancer Foundation, we took the best available data and said, we know that Black men are doing worse. Based off of the best data we have, this is what we make as a recommendation. The government will say they need a large clinical trial, tens of thousands of people that have been exposed to those types of screening, and they want to see benefit in that setting, right? So that makes it hard for some clinicians as far as what guideline to adhere to. And prostate cancer probably has the widest set of guidelines possible. I have a lot of cards in my hand, so I'm going to stop talking. Better get to reading. All right. Someone said, with regards to genetic testing, is there a correlation between a family history of cancer and a person having a genetic marker that can be found on testing?
Yeah, there can be. So a lot of times cancers and prostate cancer can run in a family because there's a genetic risk factor. Sometimes it might just be that we don't know what the genetic risk factor is. Sometimes it might not necessarily be a genetic risk factor. It could be something environmental that's shared. We really just don't know everything yet to be able to answer it well. But if it's running strongly in your family, there probably is a genetic risk factor. Prostate cancer is very highly heritable. So there could be a risk factor that's shared in your family. And, we talked a little bit about testing earlier and that you wanted to get testing. That has important implications for your kids. So if it might be good to know if you carry something that could have been passed on to your kids, because then they might want to get screening at a certain age to make sure that their prostate cancer won't advance to something that's lethal.
In my experience with genetic testing, after I was diagnosed, I was offered free genetic testing at Valley Medical for myself and 2 members of my family because there was a high risk factor. Both of my older brothers had prostate cancer, so they were sort of like my coaches. But 4 of my 5 sisters have had cancer. 3 had breast cancer and 1 died from colorectal cancer. My father died from pancreatic cancer. So after they learned all of that, they called and said, you qualify, and the testing was free for me and my sister and my brother.
That's great. That's really reassuring to hear that it should work that way. That makes sense.
This is a common question I get in clinic, so I thought I would ask, does genetic testing determine what type of treatment one should have? Maybe I'll have Dr. Calle start, and then Burcu, you could also fill in.
Hopefully in the future it will, but right now for patients that are diagnosed with localized prostate cancer, meaning cancer that has not spread to other parts of the body, no, we do not change our treatment recommendations because we don't know yet if they need to be changed. Now, we do have clinical trials that are ongoing, and I think it's going to take many years to really answer this question. But for now, genetic testing does not impact how we treat localized prostate cancer.
Dr. Darst, any follow-up?
Yeah, in the advanced setting, there are some genetic risk factors that can inform what type of treatments you might respond well to. For instance, if you carry a rare variant in the gene BRCA2, then you might respond better to PARP inhibitors. There's been some evidence of this. So in the advanced prostate cancer setting, there is some potential benefit to help guide your treatment.
Yeah. And this is an exciting area, right? There are some instances where your genetics can make you really respond well to some of our systemic therapies. So I'm thinking of like what we would call MSI high cancers where we can use immunotherapy. But again, this goes back to the importance of then making sure people get genetic testing, which is not easy to access, right? And I think in our clinical settings, we're a little bit better positioned to use those. Someone asked a question: is there a strong case to move away from? A lot of BACPAC people here. These are BACPAC questions. I love them. Is there a strong case to move away from digital rectal exams as part of a screening practice, given that they don't work?
That's so Dr. Nyame already, he's very biased already. That's a great question. And in the last iteration of the American Urologic Association guidelines for early detection of prostate cancer, I think we're making progress in the direction Dr. Nyame wants us to go towards. The guidelines finally recognize that a digital rectal exam is not necessarily that helpful in the setting of prostate cancer screening. There are studies that show that it does not really help identify prostate cancers. That being said, the rectal exam is not completely gone for patients that already are known to have prostate cancer. It could be helpful, or for patients that have elevated PSA. And so this is what our guidelines have stated. But for the prostate cancer screening process, I do think it's important to get that message out there, because a lot of men I know do not want to get screened because they're worried about that rectal exam. And knowing that it's a simple blood test, motivates more patients to get screened. And so yeah, I agree with Dr. Nyame, basically.
I mean, that doesn't mean you're going to avoid it, but it doesn't need to be the first thing you do when you're screening. All right, next question. Can you explain what you mean by 70% chance of aggressive cancer in a PIRADS 5 lesion? We are going to have a radiologist here shortly, but...
So he can talk about that as well. Well, basically, there have been a lot of studies that have looked at patients that got MRIs of their prostate and then had their prostates removed, or had a biopsy. And so we kind of are able to basically generate risks or percent chance of having a high-grade prostate cancer based on the tissue diagnosis. And then because there are a lot of studies, eventually systematic reviews have been done and meta-analyses that have basically combined all of this information. And if you look varying from one to another, you might see slightly varying numbers, but for the PIRADS 5 lesions, in general, the risk of high-grade prostate cancer is quite high, and on average, about 70%.
Next question. How early should screening be done with someone with a strong family or close family history? Is genetics accessible in that setting if you're just considering screening and not an actual cancer patient?
Yeah, good question. So for patients with a strong family history, we do recommend starting screening at age 40. And what is a strong family history? A strong family history are patients that have a set first-degree relatives that had prostate cancer at a young age and aggressive prostate cancer. Definitely patients that have family members that died of prostate cancer. And then the more family members you have, then the more that risk increases. And then there are also patterns of other cancers that might be in the family that give you a strong family history risk. For example, patients that are carriers of the BRCA2 mutation might have multiple family members with pancreatic cancer, melanoma, breast cancer, especially at a young age, ovarian cancer. Any of those kind of things that I mentioned do warrant starting to screen early. In terms of genetic testing, there are NCCN guidelines for patients that don't have cancer. What are the criteria to meet that you have to meet to get genetic testing? My personal experience in taking care of patients is that it can be a little harder to get insurance to cover testing in these situations when the patient does not yet have a cancer diagnosis, even when they have pretty significant family history. But we do have guidelines, and so hopefully, with time, that will improve to get that free testing for everyone.
All right. A lot of these questions are directed at our experts, obviously, but we'll have some questions for Grantley and David. Someone wanted clarification, Dr. Darst. Did you say 90% or 99% of our genetic makeup is the same as people and only 1% or 10% varies?
We are all about 99.9% the same genetically. Very, very similar. All the little differences that we have are, or the, big or little, they're all by a very tiny amount of the genome.
So you're saying 0.1% of the genome?
Yes, we're
right.
very similar.
Okay.
We're very, very similar to each other.
Well, as a follow-up to that question, do risk factors that you study include looking at environmental or social ones that may interact with this very small percentage of genetic difference we have?
Yeah, it's a great question. So one of the things we've been looking at lately, we're definitely interested in this, is whether some genetic risk factors depend on your environmental or social exposures. So one thing that we saw recently, which I think is kind of interesting, is that the polygenic risk score that I mentioned before that combines lots of genetic factors across the genome, we don't see any differences in how it performs by education, insurance status, and things that are kind of promising. We don't see that it's driven by any disparities, but we do see that it seems to perform a little bit better in higher BMI individuals. So if you have bigger body weight, it might do a little better, which is kind of interesting because if you have a higher BMI, you also might have lower PSA, and it might be harder to detect a prostate cancer through a digital rectal exam. So there's kind of this potential for higher BMI to be diagnosed later on with a more aggressive disease because it might have been missed because you have lower PSA. But the polygenic risk score works really well in these individuals. So if you have a high polygenic risk score and high BMI, maybe that could be a good reason to move forward with screening, even if your PSA is kind of low.
Questions. I'm going to reframe these for David, Anthony, and Grantley first. So did anyone have discussions with you about your genetic and family history as a risk for recurrence after your primary treatment?
Negative.
Simple answer. What about you, Grantley? Did that come up at all?
Yes, it came up as a potential that I may have a higher propensity for recurrence.
Okay. And in what context did it come up? Just that you had a higher genetic risk for aggressive cancer?
Well, because I am aware of my family history now and the genetic testing that came back, I've asked my doctors about it, and that's the way that it came up.
Okay. Yeah. And maybe I'll go to you, Dr. Darst first. How does genetic risk kind of lead to more aggressive cancer in 2 minutes? Just kidding. No time.
I think it probably depends on the genetic risk factor, like what mechanisms through which it might be kind of leading to a more aggressive disease. Sometimes we just don't really know. With the polygenic risk score, that is kind of combining biology across the genome. So it's not really clear why it's associated with increased risk, but we know that it is. So the kind of why is maybe hard to answer sometimes because it probably depends on the specific genetic risk factor, like how it's actually doing that. But the really important part is that it is, and that's kind of actionable information to have.
I'd like to also say, what I said before, one of the purposes of my podcast is to help men take control of their health. So part of my experience is that I have had to become my own expert. I have had to learn these things. I've had to go out there, talk to other men. I had to argue with my primary care physician to do my first PSA. And finally, I learned that I don't argue with him. I just tell him or I find another doctor. And the same thing with the learning about your genetic scores and my family history is being proactive and asking the question. So having that genetic information in my hand helped me to ask the question to my doctors.
Can I piggyback on that and also take a slightly different spin on the genetic question. I simply said negative. That's not the whole story. I had an outstanding urologist. And in fact, he's the reason I'm here, because he's a colleague of Dr. Nyame. But I have to say, you know, one of the great things about being a patient advocate is that there's no substitute for what a doctor knows or what a clinician knows, but unless you have actually experienced the disease, it's not the same. Your journey is really different as a patient. And so there's a lot of banter and there's a lot of struggle between patient and doctor. Regardless of how sensitive they are, they're not experiencing what you're experiencing. So let me just say this in a simple way. I had two really extraordinary urologists. One whose father was African American. He didn't necessarily identify himself as African American. He didn't, if I pressed, I mean, he might have said he was mixed, but he did say his father was. And he was very sensitive to the question. He's the first person who made me think about the possibility that I could develop prostate cancer. He was the first person out there. And then my plan, I changed my plan and I lost him. But I got somebody else who was also extraordinary. Both of those people were the people who did the robotic prostatectomy together. So there was a kind of continuity. But I have to also say that initially, in my experience with the second urologist, who's brilliant, was I got this thing that, well, you have prostate cancer, but it probably won't kill you. A lot of you in the room who have been diagnosed with prostate cancer may have heard those same words. They're reading from a playbook, okay? They don't know how aggressive it is until they go in. So once they went in, they got the tissue, after the biopsies, you know, after all of this, the first thing my urologist said post-prostatectomy was, you had real cancer, which scared the out of me. Okay. Well, he did say past tense, but it was also clear that up until that moment, he didn't know how aggressive it was. So we have to really, really be vigilant. We have to be persistent. We have to stay on it in the advocacy. We've got to lead the charge.
Well, we now have a 15-minute break. I want to just take a minute to thank our speakers. I went how I envisioned in my head it would go. Great conversation, great questions. A lot of them unanswered. Intentionally, I'm kind of sifting through because we'll have other sessions that might touch on some of these questions. Also, many of our speakers will be available at breaks to be approached to ask some of these questions too as well. So I think we're back here at 11 on the dot. So see you in about 15 minutes. Please come on down. You guys, yeah, grab those microphones and we'll get started with this session. Did you have slides, Omar? No, perfect. All right. So same spirit, you know, as we go along, write down your questions. I'm going to try to get to all of them. I have like 30 index cards that are unanswered. I'm going to try to get them answered and some of them in this next session. Okay. All right, Marty, the floor is yours.
All right. Thank you.
This one, is that not working? This one.
Okay. They're both working.
All
Yes.
three.
So Dr. Mian, first of all, thanks for coming today, and just on behalf of all of us patients, thanks for everything that you do to help prostate cancer patients. It's really, you know, we're grateful for the support that we get from Fred Hutch, from UW Medicine, and from the other local institutions. I just want to start by saying that.
Thank you so much, Marty. I want to say it's also a pleasure to meet you, and it's a real pleasure and privilege to be here today. Thank you.
Great. So we know that radiotherapy is very effective in treating localized prostate cancer. But in talking to the patients in my support group, we get confused because we hear all these different things. There's IMRT, SBRT, brachytherapy, now proton beam therapy. Seems like it's just more and more complicated. So can you help explain that for us? What are the different radiation therapies that are available and how do they work?
So thanks, Marty. I can absolutely appreciate how confusing that is. I will tell you, even for experts who are, some radiation oncologists and non-radiation oncologists sort of synthesizing all these different technologies and new ones in development is difficult. I would say I look at it this way. There's two broad categories of radiation. There's internal radiation, which might be the seeds inside the prostate or radioactive sources that are placed within the prostate. That's a invasive procedure that mirrors the transperineal biopsy. That's the same route for inserting the seeds. That's one major category. The second is X-rays or some kind of particle beam like proton beam from the outside that are aimed inwards at the prostate and deliver radiation to the prostate and sometimes the lymph nodes around it. Of course, what everyone wants to know is what is the better treatment, which one has fewer side effects, what should I have, right? And it varies a little bit. I think it depends on the risk. For instance, in men who need prostate-only radiation as opposed to treatment of the lymph nodes, sometimes with hormone therapy. In those men, usually the internal radiation or a short course of very focused X-ray radiation, stereotactic. So this is one of the SBRT, IMRT words, but this is SBRT. That's really my preferred approach there, focused radiation. And in men who need bigger field of the sort that would treat the lymph nodes. The same lymph nodes my surgical colleagues like Dr. Nyame are removing at the time of surgery. Those can be treated with radiation as well. In those men, that's X-rays of the IMRT sort. It's image guided, so a scan is used to make sure that the radiation is going where it's supposed to go every day, but that's spread out typically over a longer period of time. So the short answer might be, it really depends on the individual, their prostate cancer, oftentimes patient-specific factors, and then there's preferences. I live a distance away. I'd prefer to do this treatment because it's shorter. I'm close by. I have a higher risk prostate cancer. I prefer to do the kind of slower, longer course because it might be a little bit gentler from the perspective of side effects.
Thank you. You mentioned hormone therapy, and that's actually something that comes up a lot in my support group. Newly diagnosed patients are faced typically with the issue of, well, should I get surgery or should I have radiation? And we know that they're both effective. I've had a lot of men tell me, I just don't want to get radiation because I don't want to have hormone therapy. So maybe explain who actually should get hormone therapy in conjunction with radiation and why.
I hear the same thing, Marty, oftentimes in patients who are otherwise considering radiation therapy. They say, it's just the hormone therapy. I don't want that. And that might be a reason, and I think a good reason to consider an alternative approach if one without hormone therapy is there. In terms of the why would you combine these two? Radiation and hormone therapy, we now know, work extremely well together. They have this sort of 1 + 1 = 3 synergistic effect. And that's because the hormone therapy, which is medicines that reduce testosterone, they take testosterone away from the prostate cancer. They put the prostate cancer in this vulnerable state. The radiation is coming in. The idea is that it's going to kill prostate cancer cells. But the hormone therapy plus the radiation just creates this environment that selectively sensitizes prostate cancer cells to radiation. In terms of the who, not everyone needs hormone therapy with radiation, and it's really driven by risk. Historically, this risk was things like PSA, your Gleason grade, which is what the prostate cancer looks like under the microscope on a biopsy, and stage. These days, we've really moved away from that, and we're deciding which patients or recommending hormone therapy to those patients who have genomically defined risk scores that take their tumor in the biopsy, test for gene expression patterns that give us a risk score. There's several of these tests out there now. You may have heard the term Decipher. That's one that has been validated in this setting. And based on that risk, if you're in the intermediate risk category, we can tell who's going to really benefit from the hormone therapy, what length of hormone therapy we may need to use, short or longer term. And very importantly, who is not going to benefit from the hormone therapy? And it turns out to be a large proportion of men fall into that category of genetic. They may be clinically intermediate or even higher risk, but when you look at the genes of their tumor, the genetically defined risk, they may fall into a lower risk category. This disparity happens quite a bit, or discordance, I should say, happens quite a bit. And what we know from looking back at many thousands of men who've had prostate cancer, have had this type of testing, is if the hormone therapy is not helping you, if the testing suggests it's not helping you, it's probably hurting. And in those men, we have to be careful to avoid it. I say probably hurting because in those men that fall into that low risk category who wound up still getting hormone therapy, it did not increase their chance of being cured of their prostate cancer. And in several studies now, all-cause mortality, so overall survival, is decreased in men who get hormone therapy in whom it's not indicated for their prostate cancer. So that was the long answer. The short answer is we now check the biology of the tumor to decide which patients may benefit from hormone therapy and add it only in those men.
Thank you. I want to be clear. So when the guys in my group say, I don't know, maybe I'll need hormone therapy, I don't know, they should get those genomic tests done to determine whether hormone therapy will benefit them or not. Is that what they should discuss with their doctor?
They should absolutely discuss that with their doctor, yes.
Okay, thank you. The other thing that I hear from people who are considering radiation is, gee, I hate to bring this up, but we know that both surgery and radiation result in a biochemical recurrence in a percentage of cases, right?
Yes.
And people say, well, if I get surgery and I have a recurrence, I could get radiation after that. But if I have radiation and I have a recurrence, surgery isn't really an option after that. But there are options for a biochemical recurrence after radiation. Can you talk about those a little bit?
Yes, absolutely. Again, important question. I hear this in my clinic all the time. And it's in many men, understandably, this is a driver in terms of their decision for having radiation or surgery. It is true what you said. In those men who are going to need both treatments, who might need both treatments, surgery and radiation, there's definitely a difference in terms of the order in which that should be done. So if surgery happens before radiation, we do quite a bit of radiation in the postoperative setting. If you have radiation first, surgery after radiation is a more difficult surgery, and complications can be higher. Functional outcomes can be worse. And so we oftentimes don't do, in fact, we do very little, and my surgical colleagues can corroborate this. We do very few secondary or salvage prostatectomies after radiation. And the main reason for that is that there are better options to salvage local recurrence in the prostate. And so in a patient who's had radiation, some proportion of those patients at some point in the future, thank goodness it's the minority, but they'll have a PSA rise. And in those patients, we can now do things like a PSMA PET scan, which looks specifically for prostate cancer. And if they find that prostate cancer is only there in the prostate, then confirmed by biopsy, now that's a patient in whom additional therapy to the prostate makes sense. Of course, in those patients where the PSA progresses and it's not only in the prostate, maybe you'd consider something else, including hormone therapy. If it's only there in the prostate, the next options tend to be focal therapies one of which is more radiation. So if there was X-rays from the outside, you might put the seeds into that area. If seeds were done, there's stereotactic and focal radiation approaches. There's a lot of interest in the radiation oncology community in how to manage these locally recurrent prostate cancers. Again, the minority, but they do happen, and it's a difficult clinical scenario that we're now getting better and better and more used to dealing with. There's also, as you hear from my colleague, Dr. Schade, shortly, there's focal therapy approaches like cryotherapy, high-frequency ultrasound, that's focused therapy, other focal therapy approaches, or even whole gland treatment approaches that are not surgical removal of the prostate.
Well, I have to tell you my own story about this. So I had brachytherapy in 2004. In 2013, I had a biochemical recurrence. It was a very slow progression. And several radiation oncologists said, well, we don't want to do radiation to your prostate because you've already had radiation through brachytherapy. In 2020, I had SBRT, very focused, targeted radiation to the tumor that was still in my prostate. That was 5.5 years ago, and my cancer is still currently undetectable. So one success story, I'm not recommending that to everybody else, but it is a possibility, and it does happen.
Thanks for sharing that. Yeah, that's great to hear.
So I just, do we have a couple more minutes, or have we?
One more minute?
Oh, one more minute. Anything? I get a lot of questions about proton beam therapy and whether that's better or safer. Do you have any opinions about that?
So there's now been trials that have looked at this, randomized trials, big ones that have compared X-ray radiation or photon therapy to proton therapy that haven't really shown a difference. So just for some background, proton therapy is, without getting so much in the weeds of it, this is a heavy charged particle. You can control the depth of the radiation in tissue. It's delivered from the outside, but it stops, and there's no exit dose. There's some technicalities around that because the entry dose might be a little bit higher. There may be some uncertainty about the exact range position. And so this requires quite a bit of technical expertise. But the idea was very attractive because the whole thinking was by controlling this depth in tissue, you might be able to be more focused with the radiation. So therefore, it must be better. Proton centers have popped up everywhere. They're treating a lot of prostate cancer. Trials have been done that have not really shown that the theoretic and hoped for benefit in terms of better disease control or better side effects has not really materialized. Doesn't appear to be worse, but doesn't clearly appear to be better. We have a proton center here. We do treat some men with prostate cancer, but we tend to be kind of selective about who. In men who've got, for instance, bilateral hip implants, I really like the dose distribution you can get with protons. It looks better because you can avoid treating through the prostheses. So for certain situations, proton treatments may be better indicated. I think for the majority of men, many times the X-rays or photons are actually superior.
Great, thank you.
That's great. I think that what I take home from this discussion is that, radiation has a lot of variation that allows for a treatment to not be a one size fits all. And I think that's also true maybe in surgery and some of the focal therapies that are available next. So I think it's a great transition to Dr. Schade and Kojo. But I want to, again, thank you two for giving us this primer on radiation therapy. So while they're getting set up here, I'm going to introduce Dr. Schade. George Schade is Associate Professor of Urology, also an engineer running a science lab at University of Washington. George is, I'm going to call him my senior partner. But, is one of the people who's been a staple in our department for me since I joined it. So it's wonderful that he's able to share his expertise with us today. Dr. Schade's research is really focused on focal therapy. However, he is a urologist that does a lot of regular prostate cancer surgery as well. So he's going to fill two hats since we lost a speaker and talk a little bit about focal therapy, mostly about focal therapy, maybe a little bit about surgery based off of Kojo's question. So thank you. You have slides.
Hello, can you hear me? I think it's working. Good morning, everyone. Like Doc said, my name is Kojo, and Doc, thank you very much for coming over and taking my questions.
Happy to be here.
Yeah. So before I get into my first questions, just a brief intro into the reason for my question. So I was first diagnosed with prostate cancer when I was in my early 50s. And it was a bit of a shock to me because prior to that, I thought, prostate cancer only happened to, older folks, So even though my dad had died from prostate cancer, I think he was in his 70s. Well, not that I think, I know he was in his 70s. So I was thinking that at least I had about 2 decades more. And so I was shocked when I was diagnosed with prostate cancer in my early 90s. Now, one of the questions that went through my mind a lot was what happens afterwards. And and since then, I've had the pleasure of counseling and coaching a lot of folks who happen to be in the position that I was in my early 50s. And this is the question that I often hear from most folks. So regarding surgery, one of the questions that I often hear from prospective cancer patients at the crossroads of trying to decide what treatment modality is how surgery affects urinary incontinence. It's an issue which can definitely alter the lifestyle of men for good. Yet sometimes even affecting intimacy. Last thing that you want is when you're getting ready to have your groove on it, and then you have to deal with that. It's just no fun, and it's real. It's a real issue. So my question is, I know that hold on. I know that anatomically, with the prostate removed, is there any way the modern medicine can minimize the effects of urinary incontinence? Is it possible to spare one of the extra muscles so it's not such a big issue?
Yeah. Thank you for sharing your story. That definitely, and I think similar to Dr. Mian's practice too, when we're seeing men of all ages, but in particular, I think younger men, just because it's biology, right? When we're younger, we tend to be more active and we have longer to live with the potential side effects of a treatment. These are the questions that we face. How is it going to impact my urinary function? How is it going to impact my sexual function, et cetera? And actually, I think my first slide, might be helpful for this, just because it has some of the anatomy. It's not the prettiest diagram, but it just kind of graphically shows what the side effect profiles are for surgery and radiation. And one of the things that I always lead with is to understand why there's the side effects that there are for prostate cancer treatments. It's important to note that the prostate is a reproductive organ, but it's also a urinary tract organ. It's the first part of our urethra. And so anything we do for the prostate has the potential to impact both those aspects of function. And then just the rectum is right there too. And so the rectum can be an innocent bystander. And so treatments could potentially impact GI function as well. And so with surgery, comparing surgery to radiation, I always say there's a kind of a push-pull. So with surgery, there's a greater risk of leakage, both short-term and long-term compared to radiation. But if you have a big prostate and you're having difficulties with urination, like slow stream, urgency, frequency, waking up at night, things of that nature, surgery will make that part better because we're getting rid of the problem, which is the prostate. Whereas with radiation, it's the opposite. So there's a lower risk of leakage, and that's because it doesn't impact the anatomy to the same extent that surgery does. And also, in some ways, the prostate's still there. For men, one of the reasons why we leak less as we get older compared to women is our prostates kind of block things up and compensate for weaker pelvic floor muscles as we get older. And so radiation doesn't get rid of the prostate, so you still kind of have that prostate helping to plug things up a little bit. But since you still have your prostate and now it's scarred to some extent after radiation, that leads to potential changes in urination. So that's really the push-pull between the two treatments. And the reason why surgery impacts it is it's not as obvious there, but the sphincter muscle, which is the pelvic floor muscles, basically sits right at the exit of the pelvis, and then the prostate. I can't do this with the mic, but the prostate kind of sits just nestled into that muscle, and the urethra pops through. And so when we do surgery, we have to carefully push those muscle fibers down a little bit to make a space to divide the urethra. So there are some techniques that have evolved over the last, say, 5 years or so, give or take, to try to improve leakage long term. This is kind of a lot of minutia, but there's two techniques. One is called Spates Retzius sparing surgery, and then the other is called the hood technique. And in very high levels, what they aim to do is to minimize the disruption of normal anatomy as much as possible. And so we don't open some of the layers between the prostate and those pelvic floor muscles to try to minimize the impact on them. Studies have suggested that long-term, it doesn't make a difference. If you have a good surgeon, it doesn't really matter on the technique. Your risk of leakage is the same, but in the short term, it leads to faster recovery. And so there are some things we can do to try to improve short-term control.
So let's say you've had prostatectomy and you're experiencing some leakage. Is there something that could be done post-surgery then?
Yeah, that's a really good question. So I think there's sort of two layers I would kind of break it up into. One is like things that you can sort of do, right? So there's various pelvic floor exercises. The most basic is a Kegel exercise, I think.
Which is very helpful, by the way. It works.
Yeah, they work. And I think most of us have moved towards having patients do them before surgery. So this idea of prehabilitation, if you're stronger when you go to the OR, then hopefully the low isn't quite so low afterwards. And then we have you resume those. In some cases, we'll have men engage with pelvic floor physical therapy either before surgery or after, depending on your progress. And for most men, just doing the Kegel exercises and or physical therapy will get you there. Long term, depending on the series, it's as high as 90% of men will end up pad-free. In that group of men, some will still have occasional leakage, like if you have a bad cold or bad allergies or something where you're sneezing or coughing or something like that. But for practical purposes, for everyday life, you're dry. But if you're in that 10% of men long term who have more significant leakage, then there are some surgical options to try to help. Particularly if you're in the small group, about 2 or 3% of men who have pretty significant leakage long term. And so there's something called a sling procedure. And then there's also an artificial sphincter. And obviously those are more invasive, but for men who have significant leakage that's really impacting quality of life, it can lead to a substantial improvement.
Got time.
Okay, I got time.
Question.
Okay. Okay, I'll come back to this question,
Sure.
but I'm going to move to my second question. And this relates to, focal therapy. So, excuse me. So with focal therapy, specifically targeting an area, the colossal damage to some of the surrounding organs can be significant, and in some cases can lead to, erectile dysfunction. Now, I'll tell you what, as a patient, the last thing you want to hear is your doctor telling you that that's one of the, side effects. It's a game changer.
Yeah.
Yeah. So anyway, that leads to erectile dysfunction or loss of control of bowel movements. ED is a word which scares a lot of men. We don't like to hear that word. So what can be done to minimize the effects of this, or better yet, salvage these issues after therapy so that ED is not much of an issue, because ultimately it helps with our decision process, whether we want to go the route of radiation or not. In my case, I had high intensity proton after my reoccurrence. So I had surgery, and then I had radiation as well. So yeah, I'm fine though. I'm just speaking for men in general.
Yeah. I'm glad that you're doing well. Yeah. Yeah. But yeah. Yeah. Well, you dropped your glasses.
Oh, okay.
Yeah.
Thank you.
So I mean, obviously, the topic of sexual function, it comes up a lot. It's important to most men in most relationships. It's obviously it's how we often feel most connected with our partners, and so substantial changes in that can lead to substantial just changes in our self-esteem and our relationship and so on and so forth, right? And so there are, from a surgical standpoint, the main way that we try to maintain sexual function is doing so-called nerve sparing. I think actually you can see that those yellow squiggly lines represent the nerves running down from the spine at the top of the screen down to the penile tissues at the bottom of the screen. And so during surgery, we try to do nerve sparing, where we gently peel those nerve fibers off the prostate to preserve them, to help with sexual function after surgery. But even in the best of hands, there's still trauma to those nerve fibers. And then there's inflammation. And so in the short term, things typically don't work very well. We start all of our patients on either Viagra or Cialis and so on and so forth to try to help maintain blood flow and sort of prime the pump, if you will, while we're waiting for those nerve fibers to recover. But the time frame at which things recover and to what extent is highly variable. So in some cases, men they're able to have intercourse within a few months of surgery, but for many it's longer than that, and for some, unfortunately, they never quite get there. The rates in the literature are very wide. It's anywhere from 40 to 80%, and 80% is probably optimistic, to be honest. I typically tell most men it's probably like 50-50. If you're a younger guy, around 50, it's probably more like 60 to 70%. And the biggest predictors are function at baseline. We can't make you better than you are today. So that sort of establishes the ceiling. And then to what extent can we save the nerve fibers? Can we do a really aggressive spare on both sides? Is it just one side? Is your cancer kind of more throughout the prostate and we can't do any nerve sparing? That makes a big difference. And then age too, because the younger we are, the better we heal and the faster we heal. And so I think those are the biggest drivers. If things like Viagra and Cialis aren't enough, then there are a long list of other things, but they're more invasive. So there's injectable therapies that basically bypass the nerve. So they just act directly on the penile tissues. They can be beneficial in about 60 to 70% of men. There's a little suppository where they put that on the tip of the penis. It's a little bit less invasive. It's not quite as effective. And then there's like the penile implant, for instance, which would be the kind of the last thing, but obviously it works because it's a mechanical device. I don't know how much time do we have?
Yeah, we're over time. We're going to cover that in the afternoon. We have a whole section on sort of recovery. And so I guess, George, since you're here and you're an expert in focal therapy, how does focal therapy work? And because it's trying to really avoid, I think, many of the symptoms.
If you want to go to the next slide, that's a graphical representation. So this gets at what you're, really the crux of what we're talking about. So prostate cancer is currently the only solid organ tumor that whole gland therapy is the standard of care. Every other cancer. If we can spare the organ, we do. And there's a lot of reasons for that. But really what focal therapy is the concept of a lumpectomy. And surgically, it's very difficult to remove just part of the prostate. And so there's all these other energy sources we've used now to treat part of the prostate. In some cases, our radiation oncologist colleagues are starting to use more focal radiation too. But the idea is as long as we can treat the whole tumor, then in theory, the cancer control should be the same as treating the whole gland, because as long as you get it, you got it, right? But if you only treat, say, in this patient, that would be actually the left side of his prostate, even though it's on the other side of the screen. You don't do anything to the right nerve bundle, and maybe you beat up the left nerve bundle a little bit, but probably no worse than you would with surgery or maybe radiation. And if you're able to avoid being anywhere near the urinary sphincter, then in theory, you'd have less impact on urinary function as well. And so if you actually go to the next slide, there's several different options out there, and I have a graphical picture next, but in short, this is what outcomes look like. There's this really nice review paper about 2 years ago, and they basically just kind of report outcomes of all the different techniques, and it's a wide range in the literature, but one of the ways we define cancer success is a biopsy at 1 year after the ablation. So ablation means we're using a non-radiation type of energy to kill tissue, so freezing it, heating it, et cetera. And so in field, so the area that we treated, there's residual disease in anywhere from about 10 to 40% at 1 year. And those numbers are actually really close to what positive margin rates are with surgery. So that's kind of how I think about it. If we don't quite get it all, it's like we had a positive margin after surgery. And long-term, there's lots of things we can do to try to offer additional treatments. But as far as side effects, I think, at this point, it's very clear that the side effect profile of focal therapies is better on average than surgery or radiation. Urinary control ranges anywhere from 96 to 100% of patients are pad-free.
That's good.
I'd say typically I counsel patients about a 2% risk long-term. And then for sexual function, again, it's a range in the literature, but most series, if you have good erectile function at baseline, it's about an 80% chance you'll be able to have intercourse long-term. The issue is that where we stand in the guidelines, because prostate cancer is slow growing, and you can imagine if you were a patient and someone's talking to you about a clinical trial, you can either have surgery with this risk of side effects, or we have this other thing that we think has less side effects, and we're going to randomize you. If you want this thing over here and you get randomized to surgery, well, you're just going to drop out of the trial. So it's really difficult to do randomized trials. And so as a result, we just don't have the long-term data yet now comparing focal treatments to surgery or radiation, showing similar cancer control. There are 2 studies now with about 3 years of follow-up, comparing one of the techniques to surgery. At 3 years, it's not inferior to surgery for cancer control, but we just don't have longer-term data. So in my practice, most of the patients I see are seeing me because they want focal therapy, but of those that end up being good candidates, probably about a third are unable to get it because insurance doesn't cover it. So that's really the biggest hurdle right now.
Wow. Insurance.
Well, we'll have a Q&A, so I'm sure there'll be plenty of focal therapy questions and we can tackle them there. Thank you, Kojo.
Thank you very much.
And Dr. Schade for your time. All right. Our next speaker. So our last speakers are going to be Dr. Park and Mike Bing Crosby. Dr. Park is an associate professor of radiology at University of Washington and works with within a group of what I call our expert prostate MRI radiologists. And we're really grateful for them because one thing that Dr. Calle said was, well, PIRADS-5 has a 70% chance of detecting cancer. Well, there's a study that shows you that the range of detecting clinically significant cancer can be as low as 40%, maybe even lower at some institutions, which demonstrates that the expertise of our radiologists really matters. I think Bing has some heavy-hitting questions around that. And so it should be a fun conversation. So Bing, I turn things over to you.
Great. Thanks, Yaw. Dr. Park, thanks for taking the time today.
Thank you.
Can you just explain for the crowd, what is an MRI and why do we do it? What does it give you? I mean, why are we doing this MRI?
That's a great question. The MRI stands for magnetic resonance imaging. It uses a strong magnet and pulse wave sequences to make detailed pictures of our body, such as prostate and the area around prostate.
Is it accurate enough to make a diagnosis, or where does it fit in the whole diagnostic path? I mean, I don't think it's in the guidelines yet, formally. I haven't seen it in any guidelines, because there's 8 guidelines out there and they're all different. But why are urologists recommending we do this? Are they diagnosing from this thing, or are they planning surgery from it, or what are they doing with the MRI?
Most of them. So, Dr. Nyame, could you show us the next? Yes. These are various lot of MRI. Here, the MRI means multiparametric MRI. Multiparametric MRI means various series of images, such as T2, diffusion, contrast enhanced images after gadolinium contrast injection. Here we see prostate MRI can help detection and localization of the cancer, because our body component react differently from the energy from the MR scanner, such as fat shows different behavior, muscle shows different, cancer also shows different behavior. Actually, technically, not the component, the water component within the area. So here, the first slide shows dark area within the red line, means the cancer, anterior prostate cancer. So it provides visual information. Previously, probably the clinicians assess the risk of cancer based on the PSA, the risk factor, and distal rectal exam or something like that. But now we have a CC camera, So it shows the cancer. So we can see how cancer involves in the area within the prostate or outside the prostate. We call it staging. And after treatment, we can see if it has recurred or stable. The third image shows the enhancing lesion at the surgical site. So we don't need invasive biopsy confirmation. We can screen the patient's status before the biopsy. And the last image shows the active surveillance. Active surveillance is usually done for low-risk patients. Actually, that MRI doesn't show cancer. So because low-grade cancer, low-risk cancers are sometimes invisible on MRI. So for over 10 years, 9 or 10 years, there was no visible cancer. So you can keep the observation with a regular checkup. So MRI has various clinical roles.
So you hear about contrast or non-contrast, and what is the contrast, and are there risks to having this injection, and do you really need it? I mean, is it adding a value to go through the contrast issue?
The main idea of the use of contrast in imaging study is that the tumor usually has more vessels, so more blood inflow. So if we inject the contrast to enhance the tumor detection, the contrast more goes into the tumorous area. So it's like the third case, it is bright. It shows bright area. But fortunately, for MR contrast has a low risk of complication compared to iodine used in the CT. In case of a CT, iodine contrast can be problematic in renal dysfunction. But in the gadolinium contrast, there is a very low risk of renal dysfunction. But in case of severely impaired renal function, it has been reported that there is a skin reaction, like sclerotic change of the skin, but the risk is very low with newest contrast. So when we encounter the patient with a renal impairment, we assess the benefit and risk. Usually benefit is higher, but fortunately, the biparametric MRI, that means non-contrast MRI, also shows a comparable performance in detecting prostate cancer. So when the concern is too high, we can change it from contrast use to no use MRI.
That's great. Are there novel applications of MRIs coming along? Like, I know that there's a couple of products that are being advertised, like the Profound, the Tulsa Pro procedures. I think these are into the focal therapy type of things. But are they, and I know they're applying MRIs, and how does that differ from just taking an image of the MRI, of the prostate?
Could you repeat the question again?
So these new technologies that are new procedures, right, with the Tulsa Pro or the, I think there's another one that's out there that uses MRI in the process of the treatment. What is the difference, and what are they doing with the MRIs? Do you know?
As far as I know, the lesion size and location and unilateral presentation is important for the focal treatment. If the cancer is big and bilateral presentation, the focal treatment is not easy compared to the small lesion. So MRI shows the lesion size and location, unlike the CT or ultrasound. The CT or ultrasound has limited spatial resolution that can discriminate the cancer from the background tissue, but MRI has better tissue contrast, so it can provide the lesion status.
That's great. Do you want to
Well,
do
bring
questions?
our speakers down
Yeah, okay.
as you guys do your final question. So George, Omar, we got some extra chairs. Bing, you have a final question, and who? Yeah, Kojo. Marty, if you want to come down, we should have enough chairs. All right, Bing, your final question.
No, we'll just go into the crowd questions. What do you think?
You want to go straight to the
Yeah.
crowd?
Yeah.
Well, I have a question for you.
Uh-oh.
So this question is for Omar and Dr. Park. How's artificial intelligence impacting the work that you do, both in ability to read scans or deliver treatment, make treatment decisions?
Okay, to be honest, I have very limited experience in using AI. Could you show me the first? Yes.
Yeah.
I just have experience in using AI when I prepare for this lecture material. But based on the literatures, it has two potential. First one is that the AI software can highlight the suspicious area. If AI software can highlight the suspicious area, less experienced radiologist or even experienced radiologist efficiently screen the most suspicious area within the limited time. And the next benefit can be the increase the average the radiologist skill in reading prostate MRI. The reading performance varies depending on the radiologist experience. So the AI software can provide the acceptable level of performance. And even in less experienced radiologists may confidently call the abnormal finding. Yes.
Omar, any thoughts on AI use in your practice?
Yeah, maybe a couple quick ones. So we don't have a pathologist here today, but all of you know that the pathologist's role is really important in the care of prostate cancer. I say all of you know because the Gleason score that you heard assigned to your disease, that was defined by a pathologist who was looking at the prostate cancer under a microscope, and the shape of it under the microscope determines so much of what we do next. And so getting to the AI question, one of the big developments in the space of pathology is having pathologists review the image, but also training AI algorithms to go in and look at the image. And this is no longer just theoretic. This is actually in practice. It's in the NCCN guidelines that we've mentioned a couple of times. It is being used to make decisions around things like hormone therapy, because this AI is able to get in there and see things that we, with our human eyes, apparently are not always catching. And it's making our radiologists, it's making our pathologists even that much better. It's focusing their attention on areas that may be more suspicious, and it's giving us prognostic tools that are moving into the clinic. So this is going to be something that will be evolving, certainly in the time that I'm in practice.
All right.
Yeah, I wanted to say one thing too. So everybody's aware, I'm not going to advertise company names or whatever, but there are two competitors out there now. I actually am the chief commercial officer of one of them. That is FDA approved for doing diagnostics on prostate cancer using AI. We have an FDA approval. It was granted about 2 years ago, and it's just now getting into service. But those are available. We're trying to encourage urologists and radiologists to use it. It's not intended to replace anybody. It's intended to be a tool to help them better diagnose and help them better prepare for what they're going to advise you as far as your treatment decision should be.
All right.
Can I just say something?
Oh, yeah.
Yes.
A layperson. I happened to be sitting next to someone on a plane yesterday in Seattle, who was involved in cyber security. And he was talking to me about quantum AI, which is another leap, which is going to take things to the next level.
Yeah. Evolving space. I have a lot of cards. I know I'm not getting to all the questions. I'm trying my best to keep them sort of moving. So I'm going to batch a few together. And then there are some questions I may not get to that you can ask me privately between breaks. So I'll be available. This set of questions is around biochemical recurrence. And I think first, this for George and Omar, how do you define it? What is biochemical recurrence? Is it tissue left behind? Is it a new cancer coming somewhere else? How do you guys think about it for surgery and radiation?
Okay, I can start. So strictly speaking, a biochemical recurrence is a recurrence that's detected based on a lab value alone. So it's a patient who's otherwise asymptomatic and their PSA test in the case of prostate cancer is rising to some threshold, and that indicates what we've defined as a recurrence. The definition is different for surgery and radiation. For surgery, traditionally, it's been a PSA greater than 0.2. Some of the guidelines still use that. Some of the guidelines have gone to a lower PSA of 0.1. And then as Dr. Mian kind of touched on earlier, for patients who have a biochemical recurrence, then typically in today's world, depending on how high the PSA, how quickly it's rising after surgery, then sometimes we'll get a PSMA PET to see if we can find the source of that PSA. And then if either we don't find something or it just looks like it's in the pelvis around where the prostate used to be, then often we would refer that patient to Dr. Mian or one of his colleagues to talk about salvage radiation. If we find something outside the pelvis, then we'd be looking typically at like hormonal-based therapies and things like that. So after surgery, it can be really two scenarios, something left like a positive margin around where the prostate was, or it could be something that spread before that patient had surgery. And then, up the road, that little microscopic deposit or deposits got big enough that they're making enough PSA that we can detect it.
And I will just add to that, something left behind isn't always positive margin only too, which is a little bit strange. Sometimes we'll have a negative margin, but then, when we do our evaluation, we find cancers that come back. So this is a really complicated space, I think, even for us to conceptualize as clinicians. Dr. Mian?
Really nothing to add.
All right. Then that leads to my next question, which is, are there any tools that are helping to determine whether we should give additional treatment after surgery as a kind of an adjuvant treatment, or if someone's PSA is going up, what are we currently using to kind of evaluate where cancers are and what to do next? So it kind of goes to all three of you.
Maybe I'll start. I think PSA remains a really important tool for disease surveillance. It's a very good reflection of disease burden in any individual. It's not a great screening tool, to be honest with you. And some of you may have experience with this idea that PSA can be quite a few different places, and we still don't often know what to do about biopsy. But in the setting where prostate cancer has been diagnosed or now treated, the PSA is quite reliable in telling us what is happening. And so we do use that quite a bit. We are moving into an era where we're using circulating biomarkers like ctDNA. We just had a terrific seminar here in this room just a day ago on circulating tumor DNA, a blood test to look for the DNA from cancers and how that's influencing treatment decisions. The biggest development, I would say, in terms of surveillance and understanding how to treat disease in the last decade has probably been the development and now widespread use of PSMA PET scans. These are imaging tests like an MRI or a CT, but they have this functional component that allows us to find the prostate cancer. PSMA sounds a lot like PSA, prostate-specific antigen. PSMA is prostate-specific membrane antigen. This is something that is a molecule that's sitting on the surface of prostate cancer cells, and we can send an imaging radio tracer to go and find it and then use a scan to look at it. And so for prostate cancers that are bigger than typically a few millimeters, we can now see where they are. And in that setting of a PSA recurrence, what we call biochemical recurrence, we can now assign treatment decisions around not just the fact that the PSA is rising, but oftentimes where exactly the disease is in the body.
And actually, Dr. Park had a wonderful slide on PSMA, so I just put it up. Was that AI generated? No. Okay. And I guess, George, there was this question about, well, can we use genetic testing to determine treatment options or timing of treatment in the recurrent setting? Are you using any tests in your practice?
Oh man, that's a really good question. I feel like that's kind of Pandora's box right now. That side of things. So I think the short answer is currently I don't use a lot of tests like Decipher and things like that in this space. There was a time frame, maybe like 7 to 10 years ago, where we were starting to transition out of the thinking where every man with high risk pathology after surgery would get adjuvant radiation. So giving you radiation even though your PSA is undetectable to try to prevent cancer from coming back. And so there was this time period where we were recognizing that the studies that we were basing that were flawed. And so this Decipher test had been validated as a tool to assess a man's pathology to determine what his genetic risk was of a recurrence. And for men who were Decipher high risk, we were doing radiation. And if they were Decipher lower risk, we would observe them. But over the last roughly 5 or 6 years, there's been a number of randomized trials now that have shown using modern definitions and modern radiation schemes that there doesn't appear to be a survival advantage or really necessarily an advantage for metastasis to just waiting for a man's PSA to rise and treating the subset of patients who are going to benefit. Because the idea is if we give everybody with higher risk pathology radiation, we know that not everybody's going to have a recurrence. And so, roughly speaking, something like half of men are getting radiation who are never going to benefit from it. And so that's kind of where the field was. And so we're using these Decipher tests to try to better figure out who's likely to benefit. But in today's world with these more modern trials, the paradigm has really changed to, with a few exceptions, generally just observing. And then if your PSA rises, then selecting that group of men who's likely to benefit.
Yep. So I know we're at the lunch hour, but I'm gonna ask a couple more brief questions. One to George, and then the other one to the advocates on the panel that actually came from the audience. So George, Tulsa Pro has been said twice. I think as far as the focal space, there's a lot of options. Can you just kind of talk about how these different treatments vary?
Can you pull up my slide deck?
Yeah,
I actually have a figure that kind of shows most of the options graphically, which will help, I think. And so in broad strokes, there are a lot of options right now for ablating the prostate.
I have the slide up just to...
Yeah, so here we go. And so there's transrectal HIFU, which is high intensity focus ultrasound. And so it's basically a probe placed into the rectum and you transmit sound into the prostate. And the idea it's focused, so it's like a satellite dish focusing that point to a little side point, and we generate heat. The analogy I use is a magnifying lens on a sunny day. You're trying to burn a hole in a leaf. Tulsa also uses ultrasound. The non-official name is high intensity directional ultrasound. For that, it's a probe placed into the urethra. So the idea is transrectal HIFU is outside in. Tulsa stands for transurethral linear sonoblation. So it's a probe placed in the urethra, so it's an inside out. As you were saying, it's done in the MRI machine. And the reason for that is because it's not focused, they actually use feedback estimates of the temperature to modulate the intensity of the sound to drive both how much it heats and how far away from the urethra you heat. And so that's why it's done in the magnet. So those two both use ultrasound. And there's cryotherapy, which is freezing the prostate. There's something called irreversible electroporation, IRE. And that one uses electricity basically place electrodes through the perineum. So it's very similar to a transperineal biopsy, like Dr. Mian was talking about for brachytherapy. And so for that one, by passing electrical current through the tissue, it makes holes in the cells or pores. And if you give enough energy, it's irreversible. So the cells die. And then there's something called focal laser ablation, which is done under ultrasound or MRI guidance. It can be on either transrectal or transperineal. And so all of these techniques are trying to do the same thing, treat a certain part of the prostate, just using different tools. And what I tell patients is, there's currently no one size fits all solution. And so the key is trying to choose, of the tools you have available, the best tool for the specific cancer and the specific prostate. And then just to plug our program, if you just click down, we have transrectal HIFU and then IRE here at UW Fred Hutch. And I know there's someone with a question about when are we going to get Tulsa? And so I'll just get ahead of that. And the short answer is, I don't know. We've been working at it for about 3 or 4 years. Because it's done with MRI guidance, it adds a layer of complexity in that it has to be done in an MRI. And if you're at a place like UW and Fred Hutch, where the demand for scanner time is so great, and we're booking diagnostic studies, so imaging studies, like 4 or 5 weeks out, to tie up a MRI machine for 3 hours or 3.5 hours for a Tulsa case, when you might be able to do 6 imaging studies, it's a big challenge. And so currently, although there's a lot of interest with me and there's a lot of interest with our radiology colleagues, the decision has been made that we just can't tie up a magnet and prioritize one treatment over 5 or 6 patients who need an imaging study.
All right. So last question for the advocates.
I don't know
about. Someone wrote, for the advocates on the panel, what have you learned? How would what you have learned today influence your treatment? And I thought that was a really interesting question. So I don't know, Marty, Kojo, any thoughts about how the information that you're hearing about today may have guided your treatment decision?
Hello, test the mic. I mean, for me, I guess the I probably wouldn't change anything. Only thing that I'd love to have modern medicine take a really good look at it is probably have a better approach to some of the side effects that comes from, like surgery. Because I think, from my point of view, I would say surgery was great, but it fixed the problem. So I can't knock surgery. When I went through secondary radiation, luckily I didn't feel any adverse side effects at all. Other than, I mean, the most fun was in the process because it was every day for 7 weeks, Monday through Friday. So that was the most fun. But in terms of the side effects, I didn't feel any side effects at all. I was probably one of the few who was lucky. But it's good to have knowledge of all this information. But in terms of changing my decision, I'm still comfortable with my decision, except that I'd wish that modern medicine would help us have a better handle on some of the side effects. That way we can, have a
Yeah, and this afternoon we're going to have specialists on survivorship. So I think we'll be covering some of those things on what's available and what to do.
So I would just say, my diagnosis was 21 years ago, and things have changed so dramatically since then. The really exciting things that we've been hearing about today, everything from some of the biopsy techniques to genetic testing and profiling to, advances in radiotherapy, focal therapy. Certainly I might have been a good candidate for, but 21 years ago, those things were not available. Today they are. And so, subsequent to my initial diagnosis, I've been attending these presentations at Fred Hutch, the one today and the IPCR symposiums and so on. And I've learned so much that has actually helped to guide my treatment and my management of my symptoms and so on. So, I've been fortunate to have the most current information as I've been moving along this journey, and I'm grateful for that.
Yeah, I would say congratulations because you're all here. First is you've got to advocate for yourself. Your health is your responsibility. The doctors are just tools to help you along the path. So you've got to learn, you've got to know it's a serious issue that you're dealing with here. Any cancer is. I was diagnosed 10 years ago. I've had 2 recurrences since. If you have any questions about recurrences or various treatments, I've had SBRTs, IMRTs, laser ablation. I was on ADT for 6 months. I've had 5 PSMAs. So I have more pictures of the inside of me than I do the outside. So I've been an advocate for about 10 years in the VA, outside the VA, understand that journey as well. So I think it's incumbent on everybody to ask your doctor to have the discussions, talk to them. They may not have all the answers, but they kind of know where to go to help you get those answers. So my bottom line is these events are critical in your care. And I think it's the more you can listen, the more you can participate, the better your outcome's going to be.
All right. Well, another round of applause for our speakers. Thank you so much.
Okay, thank you. And I want to thank the Fred Hutch Cancer Center team and BACPAC for the partnership and for continuing to engage Zero in events like this. I think such an important partnership for such important work. So I'm going to move this over here to try to advance my own slides. Well, okay, there we go. So my name's Lisa Hall. I am, as the screen says, the Director of Health Equity with Zero. My role is focused on developing and executing the organization's strategic health priorities to improve equitable access to prostate cancer care by eliminating disparities in prostate cancer diagnosis, treatment, and outcomes, particularly for marginalized and at-risk populations, working to ensure that, every community, regardless of race, income, or geographic location, has the same opportunity to prevent, detect, and survive cancer. And a core part of my work really involves building national networks of partnerships to expand prostate cancer education and awareness, especially in those communities where the disease has the most devastating impact. And this is especially true for Black men, as we know, who face more than twice the incident and mortality rate for prostate cancer compared to their white counterparts. And these disparities are not simply the result of genetics, although we know that the component there. They are the results of deep-rooted inequities in healthcare systems and social drivers. And so that's why, I focus on addressing the factors that shape these outcomes when it comes to access to quality care, health literacy, socioeconomic status, housing, and systemic bias, and work to ensure more equitable access to screening, treatment, and support services are available across the country. This work is both for me personal and deeply urgent because of the prevalence of cancer in my own family, around a number of different cancer sites. And because every statistic is a real person. They're a real father, they're a real brother, partner, friend, whose life is on the line. And so health equity isn't just a goal, it's a necessity if we are truly going to shape the trajectory of prostate cancer for Black men and other underserved populations. And so a little bit about Zero. As the nation's leading prostate cancer organization, Zero is, the goal is to advancing a future where detection is early, support is unwavering, and care is accessible for all communities. And we've done this work for nearly 30 years. Next year will be our 30th anniversary. Zero has been leading the charge in prostate cancer advocacy, education, and support. We've helped unlock critical funding and breakthrough discoveries for new treatment, life-saving access to care. But the reality is prostate cancer is still the second leading cancer cause of cancer deaths among men in the United States, and so our mission is far from over. Some of the work that I lead includes the Health Equity Task Force that Zero has. And this year we're undergoing a revamping of that task force to expand its membership to really round out and align with the strategic priorities I've developed for the organization. And so that I'm going to talk in the next couple of slides about some opportunities to engage. Our task force might be an area of interest to some in this room. The task force is committed to eliminating disparities in prostate cancer outcomes by advancing equitable access to education, screening, treatment, and support, especially for Black men and other historically underserved communities who are disproportionately affected by the disease. And so in our group, we address health disparities, community-led solutions are some of the approach that we take, and then really addressing systemic change. And so, again, there's an opportunity, and we have a table outside, so happy to dig into any area of this presentation that you all have additional questions about. But again, there's an opportunity there for this task force as it stands today, and as we're looking and reimagining the utility of the work that they do as we move forward, an opportunity to really grow and expand the thought leadership that's at the table on this important work. some of what we offer, for those that aren't familiar, are patient programs and services. At Zero, we are committed to walking alongside patients and families at every stage of their journey, and we offer a range of comprehensive patient support programs to do this, to meet the real-time world needs of those affected by prostate cancer. And so some of those programs include 0360. You guys don't have that. I didn't type anything, I promise. I'll keep going, and we'll hopefully get the screens back up.
You type that screen.
Which one? This one? Did it? Oh, there we go. Okay. And so we have 0360, which is a patient navigation program that connects men with a dedicated case manager who can help them across financial aid, insurance, transportation for treatment. A number of psychosocial services support tools are available through our 0360 program. We also have our mentor program, which connects newly diagnosed patients with prostate cancer survivors and who've really walked that path and can really serve as a mentor and a level of support and education in a one-on-one framework. We offer education and support groups for both virtual and in-person platform where patients and caregivers can learn and share and heal together. And through our education campaigns, we've reached men in high-risk communities to ensure they understand the importance of early detection and talking with their doctor. And so all of these services are free because no one should be facing prostate cancer alone. And as we continue to grow as an organization, some of you may be familiar with Zero, and there's been quite a bit of growth over the last 2 years that has allowed us to scale and expand our capacity to really, not just through these programs, but through additional programs that we've launched within the last year, such as Blitz the Barrier, and happy to talk more about that offline. But there's a number of different innovative solutions and programs that the organization is fostering as well. And so why advocacy matters, beyond direct patient support, we're working to drive systems level change. And the next 2 slides is really talking more about systems from a state and federal perspective, but that systems change also includes systems and practice change within healthcare settings as well. And so our Zero advocacy team is actively shaping policies that improve access to care, advocate for expansion of research funds, and support patients and their families affected by prostate cancer. But to truly make an impact, we need everyone's voice. And so your stories, your experience are really powerful in the work that we do from an advocacy perspective. So I would encourage you, we have an upcoming event, and I'll talk about it on the next slide, but if you can visit zerocancer.org/advocacy, you can learn more about that work and some of the ways that you can engage around our policy work specifically. We do have an event coming up in Washington, D.C. in February. It's an annual event that we do on the Hill to really meet with constituents, meet with elected officials to really advocate for various things from a policy perspective to support and improve access to quality care. So that's called Zero Prostate Cancer Summit. I probably should have said that. This is a really, for us, well-attended, life-changing 2-day event that's filled with a lot of education, fellowship, and face-to-face meetings with senators and members of Congress. And so, again, if that's something that is more aligned with your level of service and what you're interested in doing, happy to talk more about engaging there. And early bird registration for that, shameless plug, starts October 15th. And also we have our 0+1. There's some more information out on the table. Our 0+1 caregiver retreat that's happening in Atlanta, November 15th through the 16th. And this is really a transformative in-person gathering that's dedicated to the heroes behind the scene, the caregivers. This is an audience, this is my managed care days now coming back, but this is an audience that I really I hold near and dear because the work of our caregivers is unwavering. And I say that from working in a number of disease states, most recently Alzheimer's. And so when we talk about the work of caregivers and really knowing how to be advocates for them and supports for them. The work that we do at Zero is really important to support those spouses, partners, parents, and friends that work with prostate cancer patients and their loved ones. So this retreat, more information on that as well as at the table for those that are looking to get involved. We know that caregivers can be really overwhelmed around this work and feel isolated and exhausted, but it can also be really beautiful and deeply meaningful work. And this retreat honors the truth, and we'll hope you'll consider joining that event. And so as I close, I just wanted to remind everyone that, you know, this work matters, and I think I'm preaching to the choir on this. So I fully acknowledge that your voice matters, though, and your stories matters. I don't have the information here, but happy to share it. We just recently developed a veteran survey, to really solicit the voice of veterans as it relates to prostate cancer, and I can share more information on that. That was just recently released, but that's an effort, one of many that we make to really reach out and hear the voice of those walking this experience through their lens. And so together we can raise awareness, advance research and treatment, eliminate disparities, and support every man and every family facing prostate cancer. Whether you're involved by advocating, attending an event, supporting a loved one, or simply spreading the word, you make a difference. So thank you. And then just the last call to action for the events that I mentioned and where you can find more information about that. Thank you.
So very quickly, someone has an insulin monitor, I think, that was found. Does this belong to anybody in the room? Okay, then we will hold on to this. And if someone does decide to want to claim that, Ritu has it. All right. Zero is a really important partner for our research team, where we are looking at a lot of the activities they do, refining them, improving them, studying them, formalizing them. So for instance, a mentor program is something that we are looking to improve and test and figure out how to make it more socially and culturally relevant to a wider population. And so that their willingness to engage with us is really important. And I think we all, as a group, have learned a lot from each other on how important it is to have peers as support. So stay tuned, a lot more in the peer support space for us. We're a little bit behind schedule, but we'll get caught up. We'll borrow the time from my closing remarks, which will be short. So why don't we go ahead and bring up Ray, Palko, and Ken to talk about nutrition and prostate cancer. Any seat in a microphone. Ray is a clinical dietitian with the medical nutrition therapy services at Fred Hutch. For some reason, I feel like Ray is going to be more popular than any doctor we've had up here. This is the most common question I get. So Ken, you're the interview. You're Oprah. Get us going.
Can you hear me? Okay, great. So Ray, my first question, are there any new developments in your work you're particularly excited about?
There are a few. The one thing that's coming to mind first is a focus. Am I not on?
No, but you project well, so you're pulling us a little bit. Try this.
Is this thing on?
Yeah, there we go.
All right, there's probably actually more than a few and a lot of things that I'm excited about, but I know I need to reel my time in. One aspect is it's very sort of personal to me, and if anybody's older than me, it should be personal to all of us. We all age, and we all start to lose muscle mass with time, and this is a big focus throughout the dietetics profession overall.
but it's taken a little extra when I'm working with folks on ADT is a really big deal there. So as dietitians, we've actually started at the Hutch doing a technique with our patients where we can just do a nutrition-focused physical exam. There's all these high-tech things where you can go and get MRI and all this scanning of your muscle, but we can simply palpitate a few of the key muscle areas and give you some insight. It seems like you might be losing muscle, and we can help you figure out how much protein do you need to go alongside that. And so really a lot of my work, and there were some folks out around lunch that were like, wait, a prostate cancer dietitian? That exists? What's that? A lot of our work is working with folks on ADT to figure out how your diet and your physical activity can mitigate those nagging side effects of the ADT. So that's something that's really been interesting for me, getting that focus on the lean body mass, figuring out how do we eat right to support that without too many calories that we're unintentionally gaining weight. That's a big focus point of mine that I'm really excited about. I'll pause it on that one and turn you to your next question.
Next question. Nutrition-wise, what can folks do to get the biggest bang for their effort?
Great question, and I have to give two different answers to this one. I can't give just one. The first answer I would give, whatever you can do to get the best bang for your buck is whatever you can do that you can sustain and do regularly. Like, it's great if we go and eat a really healthy meal and we're thinking, oh, this is wonderful. But if you only do that once, it doesn't really do a whole lot for you. So even, the old saying that everybody's heard, we used to say back in the day, an apple a day keeps the doctor away. Even something like that, even if you're going to a fast food restaurant for 3 meals in a day and you can cut out, maybe knock off one thing of fries and bring you an apple instead and eat that, that's going to be great. So it's whatever you can sustain. I'm a huge fan of greater than statements. One thing I do a lot with people when they're working on their unintentional weight gain is say, mobility and strength are greater than thinness. We shouldn't all have this goal that we want to look like a stick. We should have a goal that our body can move us about the world and do what we need to do. Another recent greater than statement that just came stream of consciousness when working with a patient who was really doing wonderful, beating himself up for not being perfect. I said, number one, there's no such thing as perfect. Number two, consistency is better than perfection. So whatever little thing you can do that you can repeat and you can do day after week and on will be great. But my second answer to that is going to violate a little bit of the kind of dietitian ethos, and I apologize to the rest of my cohort. We are generally, our thing is that all foods can fit in one manner or another, but I'm going to tell you, if you want to make a real quick and easy improvement, knock out any sugar-sweetened beverages. We don't want to be demonizing anything specifically, but sugar-sweetened beverages, things like soda pop, are really unique in the fact that they don't make us feel full at all. So you compare that against another food that might be, quote, less healthy. Well, you can drink all of your calories for the day with soda and you're still hungry. And then you eat all your calories. So that, and not just get rid of them. Okay, maybe if we're drinking 6 sodas a day, let's work on what does it look like with 5 for a week. And we see how we go. And we make these, again, back to that sustainable piece, slow and gradual changes.
Thank you.
You're welcome. Now it's my turn. All right. Gail is now Oprah. All right. Where was that question? Aha. So Ken, you're going about your day-to-day life. You're doing your thing. You get hungry. You need something to eat. How often do you consider the impact of your nutrition on your prostate cancer? And if you do consider it, what are you trying to do with your eating to address that?
So I'm a 10-year survivor. So when I think of nutrition, it doesn't necessarily, prostate cancer health is maybe not at the forefront of my mind, although I'm always thinking of, I want to avoid a recurrence. But when I think of a prostate healthy diet, that could also be a a heart healthy diet. And what I'm kind of focused on most recently is my A1C. I was in a cooking class that had a nutrition component with it. And they talked about added sugars. And that's something that I always read the saturated fats, the sodium, the cholesterol, but I didn't pick up on the added sugars the way I should have. And once I started looking at that, you talk about soda pop and things of that nature, it really jumped out at me. So right now, my A1's about between 5.9 and 6.1. I got up as high as 6.3, and the doctor's like, Ken, we need to address this. So one of the things I'm focused on is trying to avoid those added sugars. That's probably my main focus these days.
No, that's an excellent focus to have. And like you mentioned, you were looking at saturated fat. Added sugars, forgive me, I cannot remember exactly, but I've been a dietitian about 13 years, and I believe that added sugars was added to the nutrition facts label mandated in the time I've been a dietitian. So sometimes you even run across an old packaged food, it doesn't even say added sugars on it. It's like, okay, so number one, how old is this? Do I want to eat it? And number two, there's some incomplete information. But it's so great to hear you say that, because nutrition that's going to foster good metabolic health, like help lower an A1C, be good for our heart health, also overlaps with the nutrition that's going to help lower the risk of prostate cancer, lower the risk of recurrence. And this is another thing I'm excited about, but we're a few years away. The way we eat may even slow the progression of the disease. And the test tubes and the rats are telling us that if we eat more plant food than animal food, that may even have some power to lower progression of the disease. So it's all kind of one closed loop. You don't eat healthy for your foot, but different for your brain. You don't eat healthy for prostate cancer, but different for high blood sugar.
Thank you. Thank you.
You're welcome.
All right. I do have a question for you. Maybe we'll save it for Q&A. So a round of applause for you two. Next, we're going to talk about mental health. We have Chris Brantley. Hi, Chris. And we have Patrick. So Chris is a physician's assistant at Fred Hutch, teaching associate in the Department of Psychiatry and Behavioral Sciences at UW. Chris, thank you for taking time from your weekend to be with us. Patrick.
Okay, well, I was writing notes down, but I realized that 90% of the time I can't read what I wrote.
I'm getting there too.
Yeah, these are what the new and improved.
I love this.
Yeah. Anyway, I want to thank you for being here, Chris.
Definitely.
And it probably goes without saying that any sort of major health concern a person has could be traumatic, could be very stressful. So with prostate cancer, we know there are probably some major mental health issue that a person could undergo while they're being treated, during the treatment, and afterwards. And what are some of the major mental health things that prostate cancer patients go through?
Sure. Thank you for the question. I think understandably, any kind of cancer diagnosis is going to come with a fair share of feelings, right? Thinking for anyone in this room who's been affected by cancer personally, or family members, think about that first moment when you found out, all those feelings and emotions that hit you, right? Oftentimes here in the world at large, we like to think that mental health is somehow separate from our physical health, right? But they are very much connected, right? If the mind's not right, the body could be perfect, but you're sitting there not wanting to do anything or wanting to live your life, right? So when it comes to the impact of cancer on mental health, ultimately the question I think is most important is, are you in the midst of all these feelings and emotions, all the things that are going on, not just the physical side effects of treatment, able to find that space for yourself to experience these thoughts and feelings and feel like you have the room and the support needed to make it through, right? So you're not feeling like you're just white knuckling, right? Trying to get through day to day. That little thing is just gonna throw you off the rails. So, and I know with any kind of cancer diagnosis, there's always questions about impacts on function, quality of life, right? As a student, and I'm gonna apologize. One of the reasons I got into psych is because I like to talk. So you can always play me out when you want to, right? If I start talking too much. One of my first experiences when I was a student doing my rotations is sitting in a room with a patient, with a man who status post his prostatectomy, and talking about how he could no longer function as a man, in his words, and how he could no longer even hold his urine, and just watching him cry as he was letting it out, right? And understandably, these questions impact us, right? With these feelings, these thoughts, they're very real. And so being able to acknowledge them is an important part of our health, right? And especially with any kind of cancer diagnosis, but in particular for men and and a prostate cancer diagnosis and the impacts that may accompany it. These are big things, right? So, and definitely impact our well-being.
Okay, well, thank you for that.
Sorry, I sort of ramble.
Well, I will say this, when I met he and his wife outside, they both said that she knew how to tune him out, but she would love having an audience that would listen to him.
Survival mechanism, she's back there.
Okay, so kind of a follow-up question. I know that things like anxiety and depression can come into play. How are those kind of manifested, and what can a person do to kind of overcome that?
Yeah, and then, I think there's always a risk of, we all get sad, right? There's a difference between sadness and depression, right? We all get stress, we all worry, and there's a difference between that and anxiety. Right? So I think one of the key questions I always consider when I talk to people is, how is it impacting your quality of life, right? It's okay to be sad, right? It's okay to cry. It's okay to experience feelings and emotions, right? But is it getting to the point where all of a sudden, I don't really want to go anywhere. I don't want to spend time with my family or my friends, right? I just don't want to sit here. Maybe I'm not sleeping enough, or I'm sleeping too much. I don't really enjoy anything anymore, right? So once you start to see those real, I would say, functional impacts of that anxiety, I think those are things to watch out for. When all of a sudden, maybe the people in your life are like, hey, I noticed that you don't really want to do anything anymore. They're like, are you feeling okay, right?
Okay. And I know for me, from a personal standpoint, I was diagnosed, I guess, in 2005, and I was sharing with Chris and his wife that I don't even think Google existed back then. And so trying to find information, knowing where to go to, and just there was a rash of emotions that went through, not so much from the anger standpoint, but the kind of why me. And I know that if there were support groups that were around during that time frame, I wasn't aware and didn't know how to reach out. And so for me, it became my wife, my caregiver, my wife. And so how important are caregivers and support groups in helping men who are undergoing, cancer therapy, the treatments? How important are those support groups to help address that?
And I would say incredibly important, right? I think it's hard enough to be going through prostate cancer, but even more so if you feel like you're going through it alone, right? One of the common things I hear from patients that I talk to here at Fred Hutch is, oh, I don't really want to talk to my partner or my wife or my kids or my friends about it because I don't want to burden them with how I'm feeling or what I'm going through, right? So feeling like you're going through this on your own and alone, it makes it that much harder, right? So knowing that there is a community out there where you can get that support, right? And you can have those conversations and you can talk about these things and the real impacts that it has, right? I was talking to a patient and I remember it sort of broke down, started crying, and he apologized for crying. It's like, I'm sorry, it's weak. I was like, no, how could you not feel what you're feeling? How could you not be scared? How could you not have all these emotions? We spend so much time, some of us, maybe TMI, but we spend so much time trying not to feel those unpleasant things or think those unpleasant thoughts, but they're a part of who we are. So having that space where you can talk about it with others, whether it's your wife or your partner or the support group, I think is a great idea. So you don't feel so alone.
I know that it's well documented that men and women have different ways of dealing with the emotional type things. I know for me, when I was going through, it was years later, and I finally kind of got the gumption to go and talk to someone, about what had happened, and they said, no, you basically, when we sat down and had a chance, you were going through anxiety and depression. I was also diagnosed with PTSD, and so I'm wondering, because of what would you say to men as far as to get them to sort of look at it from a standpoint of something's going on, I need to be able to open up and talk about this. I know, 'cause I talk to my wife and she always says, you men just don't know how to express yourselves.
Yeah, that's very true. I think my wife would say the same thing. Right? We'll watch one of those sad movies together, and I'm just sitting there stone-faced. She's like, "Why don't you have human emotions?" So I think that same kind of way. So I think part of that is being able to acknowledge that, hey, this is suffering. this is a hard thing, right? Part of being kind to yourself is being to acknowledge that this is painful, right? And having that conversation. Maybe you don't have the words for what it looks like or what it sounds like, but you can see when it starts to affect, like, oh, I don't know. All of a sudden, my kids are talking to me and I just feel so angry. Or, I just want to stay in the room. I don't want to go out and do anything. And I just don't want. So when you start to see those changes in your life there, then it's, so the patient I mentioned earlier who was crying, it was one of the things I mentioned to him is, so a little bit of background, I was in the Army. I was an Army medic for a few years. And yeah, what? Hey, and I told him, like, the most amount of men I've ever seen crying was in the military, right? And going through those real hard times and seeing buddies get hurt and injured and killed and all those things there that accompany it, right? There's nothing wrong with feeling, right? But allowing yourself to acknowledge that these feelings are a part of you, right? All of it, right, is important. And I think having that conversation, that's one of my hopes that here in psychiatry is what we're here for, to give you that space to have that conversation where you can talk about these things. Maybe if you don't want to talk about with your friends or your wife, but so you don't feel so alone in what you're going through.
Okay, kind of my last question here is, when we talk about the mental health aspect of it, but when did that mental health, those issues that surround that, begin to manifest themselves into physical shutdowns and things?
Yeah, I think it's different for everyone, right? And oftentimes it almost feels, I think, it can almost get cumulative, right? Like I've had patients who say, I just can't take any more bad news. It just sounds like bad news from bad news and bad news. And it just feels like that, it just gets so thin there, trying to manage all these feelings and also continue to be that person in your life for yourself and the people around you, right? So I'd say once you really start to see that impact on, like, you just feel like, I'm not really living, I'm just surviving, right? I'm just trying to make it through to tomorrow. And hey, maybe that's a good time to say, what am I feeling? What am I thinking? Having that conversation with someone as well.
And so if you could talk to just recently diagnosed a person that's undergoing, what would you tell them as far as things they could do to basically be on the lookout or kind of knowing that there are things that they can get help with as far as, mental health issues, those kind of, my first thing that happened to me was like, some kind of curse words and why me?
Sure, yeah. I think if you find yourself in that place where you are really struggling, right, where you feel like you're just getting by, right, you're doing everything you can just to make it to the next day, right, and all of a sudden those other aspects of your life, right, are falling by the wayside, right. Ultimately, when I talk to patients, my thing is, so much of the things that happen are unfair, right? Nobody should get cancer, right? Nobody should be put in this situation, but here you are, right? And trying to acknowledge that and accept the feelings that accompany it while still living that life that's meaningful, right? And rich and full, doing the things that are important to you, right? If all of a sudden you don't start doing those things and you notice that you're maybe not living that life that you want to be living, then I think it's worth reaching out and having a conversation.
Okay, thank you.
You're very welcome. Yeah, I don't know if I'm out of time here, but yeah, I'm just curious from our end and asking you, what kind of resources, what kind of support, and I know 2005 was a while back, what would you like to have seen at that time to help you?
I think finding someone to talk to that could understand, and I share this story because when I was diagnosed, I figured I'm a fairly learned person, so first my thing was, well, I had no idea what really prostate cancer was, so basically the educational resource I felt weren't available. And then I did the famous adage. I said, well, let me call my dad up and find out kind of something. And his response was, well, if you know your Uncle Fred and I, we both had enlarged prostate, so it's probably nothing to worry about. So I'm thinking, well, that's real helpful. And then I guess there was a feeling of kind of being alone.
Sure. Yeah.
Because men don't share stories.
Yeah.
For the most, unless yes, unless they're like sports stories or something. And so for me, it was trying to find out kind of, who do I talk to?
Sure.
And I just had I guess it was kind of a fortunate thing that my wife, whose mentor happened to be the commander at Fort Lee at the time, well, my wife told her, and she said, well, he needs to talk to my husband, Craig, because Craig had prostate cancer. And so for me, it was just finding one person, who I could kind of talk to and try to kind of share kind of what I was feeling, because certain things you can address to your spouse, but certain things that felt like, well, she won't understand this because it's something that affects me. And so when at the time there were like two options, either brachytherapy or removal, and there was like, and the doctor simply said, hey, you'll make your choice. I'm like thinking, this is like, that famous, the lady or the tiger behind the door. I don't know. I don't know what the long-term effects are going to be. And so I felt like just having more information would have been critical and more people to talk to.
Definitely. Yeah, I think as a man, when people ask you how you're doing, what's the most common response? Yeah, I'm good. I'm fine. I'm okay. And like, people just leave it at that, right? So I think, definitely being able to acknowledge that it's okay to not be okay, right? It's okay to feel. It's okay to have these things. It just means you're human. We all experience it, right? I'm sure your experiences in the military too. You've seen all kinds of emotions from all kinds of people, and ourselves included, right? But realizing that you don't have to go through this alone is important, right? So you feel that. Yeah.
Thank you.
Thank you as well. And thank you, everyone.
All right. Thank you to Chris and Patrick. Chris, do you guys train on that soothing therapy voice? I felt like I was in session. All right. Next, we have Dr. Marah Hehemann, associate professor. Congratulations on your promotion, and one of my closest friends in urology. Here to talk about sex med from the urology standpoint. She's paired with Grantley, who's going to serve as her interviewer. No, promotion in urology. I will, yeah. No, I will, you let me know when you want me to move through your slides, ma'am. Are they here? Do we have your slides? We'll get them. Okay. We'll get started. I'll let you kind of turn the screen off or image mute. Oh, look at that. Boom. Yes. I'll even make sure it's turned on. Mike.
Hi, doctor. Good to meet you.
Nice to meet you. Is this on?
Yes, it is.
Okay, great.
But this one is on. I'm not sure what yours.
I think it is. Yes.
You're both live and on the clock.
Okay, here we go.
That's dangerous.
So I'm sure this topic has generated lots of interest in men and the people who've seen it on the agenda. So could you explain to us what is sex medicine?
Yeah, so as Dr. Nyame sort of introduced me, so I am a urologist. I did the same type of residency as Dr. Nyame, and then we both did subspecialty focused fellowship training. So my fellowship is in men's health, which is a broad term, but it really focuses on sexual medicine, so the restoration of erectile function, penile reconstruction, male continence. So I do prosthetic surgery, both for continence and for erectile dysfunction. And then I also treat men for infertility. So kind of the whole spectrum of benign urology, and prostate cancer survivorship from a urology standpoint also falls in with what I do and is a very large piece of my practice and very near and dear to my heart.
Thank you. So in your opinion, my experience from talking to men, and again, listening to men on my support group and interviewing people for my podcast, has been about this question about penile rehabilitation and Kegel exercises therapy. Mm-hmm. And there seemed to be some discussion about should it be pre-treatment or post-treatment or after physical therapy. What's your opinion on when's the best time for this to begin?
Yeah, so I think it can be individualized. So just to go back to what is penile rehab. So penile rehab, for those who don't know, is a protocol for helping maintain the function of the penis and the size of the penis after prostate cancer treatment. I like to make an analogy. So the analogy is after you get a knee replacement, you wouldn't just, if two people get a knee replacement and one sits at home on the couch and the other person goes to physical therapy regularly, which one is going to have the greater mobility in their knee replacement? Which one's going to have the better overall long-term outcome? We know that the knee is not going to be the same as it was before for either person, but the one who goes to physical therapy is probably going to have more functionality in the long run. So that's sort of the concept behind penile rehab, is just maintaining function over the long term, especially after radical prostatectomy. So a prostatectomy can deeply impact sexual function, especially in the short term. And so doing steps to help maintain penile function, we think can help, in the long term, either restore erections or at least maintain the health of the penis. So, that's okay.
So give us a little
That's
bit
the concept.
more about what's involved in penile rehabilitation.
Yeah, so in general, we think there are a few different types of tools we have for penile rehabilitation. Most of you who have had prostate cancer treatment have heard of Cialis, or just men in general. So Cialis, Viagra, these types of medications have been around since the early 1990s. And that is the mainstay of penile rehab. So these medications help just enhance the blood flow to the penis. So a penile rehab protocol would just be based on first taking one of these types of medications every day. It may not get you, a rigid erection, but it would help just support blood flow into the penis, again, just for the health of the penis during this period of sexual dormancy after treatment. So that's the mainstay. Another treatment that is very often used in rehab protocols is a vacuum erection device. So this is a cylinder that fits over the penis, and it pulls blood in mechanically by suction to just help, again, stretch the penis out, maintain length, maintain size, and the health of the penis during this period, especially after prostatectomy. Some individuals decide whether or not they want to try injection therapy. So that is a shot that can be, we do a teaching session in my clinic to teach you how to give yourself a shot into the penis to help really get good blood flow into the penis. And again, these are mostly just aimed at the longitudinal health so that restoration of sexual function can be as optimized as possible.
Yes, thank you. That's interesting for me because I tried the injection, and it didn't work for me very well.
Yeah.
But I found out after coming to your clinic that I was doing it wrong.
There you go. I was going to
So-
say, who taught you?
Wait a minute. Re-advertising here, okay?
You guys could, it was not at your clinic. Your clinic showed me the way to do it.
Yeah.
So this question came from my wife, and I wanted to get it in here, is what's the best way to stay connected and intimate during this time of sexual recovery?
Yeah, I mean, I think these questions are very thematic in this sort of section here of mental health and connection. We know that cancer survivors aren't just in a vacuum. Your cancer diagnosis and treatment affects many people around you, especially your partner, especially a spouse or intimate partner. There's a lot going on with changes in your body image, changes in your confidence. We heard from our last speakers, depression, anxiety, PTSD, and those are deeply impactful on a relationship. And then, of course, the sexual function and ability to be intimate like you were before, this treatment or this diagnosis, it changes, certainly. And so there are a number of different resources that I like to refer patients to. There is the Northwest Institute on Intimacy, the AASECT. Don't ask me exactly what that totally stands for, but I can give it to any interested individuals here. I do think that talking with someone together is really helpful. I would love when patients bring in their spouse to have these conversations. It's like bringing your spouse when you go through the cancer diagnosis talk. 4 ears are better than 2, and you really, we're going over a lot of different treatment options. We're going over to a lot of education, and especially for talks about intimacy. Obviously, it's a two-way street, so it's got to make sense for both partners. And so I love when partners come in together.
Yeah, for me, I wanted the prostate cancer out of my body after I had my diagnosis. And like I said, I had 2 brothers who had prostate cancer before. One had the prostatectomy, one had radiation, and they both talked very highly of them, people I spoke to. But I decided to go to prostatectomy. But I didn't understand the gravity of the side effects and the post-surgery erectile dysfunction and some of the other things. Have you heard some of the guys talk about today, having a better understanding going into it about one of the side effects are? And I didn't have that very much. So I can tell you it's been a very frustrating experience after that, and very, I don't know what a word is, but it's been very frustrating, and took nearly 2 years to regain any sort of real erectile function. So I guess what would some of your advice be for patients who are going through that?
Yeah, it depends on the stage where you are in terms of are you 1 week after surgery, or are you 6 months after surgery? I mean, my main goal as Dr. Nyame knows, because we share many patients, is really to be an educator and just a supporter. I want to walk through all the different treatment options with you and, find the strategy that makes the most sense for you and your partner and your life. For some people, that may mean finding new forms of intimacy that don't involve a rigid erection. That's fine. For some people, it may mean a penile implant where, you have more spontaneity and, so it's mostly being open and honest. I think that, again, sounds like kind of a theme of the past couple of talks. And I really just want to be a supporter and an educator.
So finally, what would you like us to take away from that? What's the one big thing you would like us to take away from your work and the work that you do, and how it helps prostate cancer patients, and so not just survivors and families?
Mostly really hope. We know that prostate cancer treatments are life-saving treatments, but they do have some side effects. And my field focuses on how we mitigate those side effects, how we can restore intimacy, restore continence. And many folks just don't know that these tools exist. And so I want you to feel hopeful that we do have many tools in our toolbox to help with sexual function, help with continence. And then please spread the word, because you can't tell you how many patients I see coming in who have been leaking into pads for 10 years, and they never knew that there was a few different types of treatments we have that could make them have much better control, if not complete control. So, and same goes for erectile function. We can restore things. It's, again, like that knee replacement. It's not going to be the same as before, but there is a new normal, and certainly hope for that.
Thank you. You have any questions for me?
Yeah, first, I want to thank you for your openness and honesty about your treatment path. Did you run into difficulty seeking a specialist in these fields, or, what was your sort of pathway through? How did you navigate the survivorship piece in terms of sexual function and continence?
I wouldn't say I had a difficulty finding specialists. I had a difficulty finding good specialists. That's a different thing. And there are many specialists out there. My first specialist was not that good, either in bedside manner or the person that they referred me to before I met Dr. Nyame as the sex therapist was also not very good in helping me with that. But getting information and learning and meeting people, learning, like you said, there are other ways out there. There are better forms of treatment out there. And getting back to what we said before, becoming your own patient advocate, learning to ask questions and not giving up. After I came to the first prostate cancer symposium and I met Dr. Nyame and his team, and then we started talking. He started referring me to other resources that I found was very helpful, reduce some of the frustration. So I would say for what I would like to see, if I could make some suggestions, is that if there could be some better consistency in how patients get advice and referrals and maybe a rating system, you know, because maybe I'll start a rating system out there for people who give you this kind of information, because it's important. Because like you said, you know, I was frustrated, and you said there's men out there who've been having incontinence for 5, 10 years, not knowing that there are solutions out there. And think about how much misery they've been through, how much frustration they've been through, how much mental health frustration they've been through, not having good information.
Right, right. Yeah. Certainly I see it, and, you know, I do as many of these talks as I can to try to spread, you know, shed light on the treatments and the good people that we have here. So I appreciate the opportunity to be here.
Thank you.
Thank you so much.
All right, thank you guys for that. And to our last speaker for this session, Lisa Price. Lisa, I'm glad you're healthy and okay. And Marty, all right. You know, I want to just say that a session like this, having multiple speakers, really focusing on it, comes from direct feedback from the people in this room. So, you know, we'll try to get to all the questions that we can, but this is such an important part, especially with prostate cancer, surviving with your cancer and all the different ways. So I want to thank everyone who's been here so far. I've already introduced Marty. Lisa is one of our physicians at Fred Hutch, a teaching associate, and is going to talk to us about integrative medicine. Dr. Price. Do you have a microphone? No, you do not. This one should be live. Thank you for being here.
I think we're both good to go here.
We sure are.
Okay, Dr. Price, very nice to meet you. And I have to say, this is the session that really touches my heart. As anybody in my support group will tell you, I'm just sort of fanatical about diet and exercise and the things that we do to take care of ourselves. The thing that I wanted to ask you about first is the title. This is integrative medicine, and that's not a term that I'm particularly familiar with. So what does that actually encompass? And is it actually medicine? I mean, so tell us about that.
All right. I know that one of your original questions was alternative medicine. What is alternative medicine?
Sure.
And oftentimes, so let me start out by defining that and then telling us what, or mentioning what we do here at Fred Hutch. So alternative medicine is usually referring to a medicine instead of standard or conventional medicine. And oftentimes with regards to prostate cancer, some of us, and I'll just say it because it's in the general ethos of the social media world, things like hyperbaric chambers, mistletoe therapies, high-dose vitamin C therapies, all those things may be referred to alternative medicine again instead of. But the problem that's associated with alternative medicines or the use of alternative medicines is that we don't have the data, we don't have the research. And as we all know, time is of essence, and when we're dealing with any kind of a cancer diagnosis, including a prostate cancer diagnosis. So we don't have time to be fooling around with these methods that we just don't have data on. So, but then we get to the definition of integrative medicine, right? Integrative medicine. And integrative medicine is a form of medicine. It is medicine that is safely complements standard treatment therapies. And these are supported by science or so they're science-based and or science-informed practices. And these include mind-body practices that we could talk about more if we have some time. Diet and lifestyle modifications, as my colleague Ray Palko spoke about, and my other colleague spoke about with mind-body practices, addressing mental health, but also supplements and herbs, because we know that about 80% of our patients or 80% of folks use some type of herbal or some type of nutraceutical or supplements. And so we want people to be using these very safely during practices.
Let's pursue that because I have a lot of guys in my support group who are very interested in supplements, turmeric, garlic, pomegranate juice. I mean, you know the list better than I do, but these are things that are brought up over and over again. And how should a patient decide whether these supplements will be helpful or appropriate, or in some cases potentially harmful? In other words, which ones to choose, if any, and then where to safely acquire them? Because I understand there's wide variation in the supplements that might be available in a local drugstore versus a health food store or whatever. Can you talk a little bit about that?
Yeah, there were a lot of questions in there, but I'll try to remember this. First of all, how can a person know what is safe, or how to safely use these? And that's where a medical professional comes into play. Here at Fred Hutch, when a prostate cancer patient or any type of cancer patient comes to see us, and they're on a list of supplements that maybe more than 5, we immediately send that list to the integrated medicine pharmacy. And then integrated medicine pharmacy does a sweep of the literature to determine whether or not those will have contraindications with their medications or with anything, actually. And so that's one way that's very helpful. And then as far as the quality of supplements is concerned, we have many resources that help patients determine what are good supplements and what are not good supplements, in particular with regards to herbal therapies.
Thank you. You mentioned sort of the mind-body integration, and could you talk a little about that? I've got guys in my support group who are convinced that yoga is a really good practice if you have prostate cancer. Others talk about meditation or Tai Chi. Is that part of what you might recommend?
Absolutely. Yeah, mind-body therapies are what we call part of the foundations of health, and looking at the foundations of health, and particularly with regards to stress. And then we could also get into the physiologic effects of stress and how they affect the immune system, and also how they affect developing side effects, right? And so we want those stress to be low. And so mind-body practices such as yoga, guided meditation, breathing practices, Tai Chi, et cetera, are all ways to decrease stress. And so yes, to decrease stress and then decrease cortisol and other stress hormones, and decrease these unwanted side effects, and also having beneficial impact on the immune system. But I also want to address another thing, is quality of life, right? Quality of life. Pulling us from the past worries and the future worries, and bring us into the now, so that we are fully present in the moment and in enjoying our life in the most wonderful and large way. And that's what mind-body practices are really, really good at.
That is, yeah, thank you. That's huge, because I think as cancer patients, sometimes it's difficult for us to recognize that, you know, we have an uncertain future and sometimes a fairly troubled past in terms of our disease and our treatment. But we do have this time now to live as best we can. And it's not always easy to be in that moment and to be more than just a cancer patient, but to be a whole person.
Absolutely. And all of us, in fact, yes, a cancer diagnosis can bring that uncertainty, but I think all of us in general, to be able to live a better and a more full life, need to be fully in the present. And that's where mind-body practices come into play.
I had one other thing that I wanted to challenge you a little bit on, and that is the description of your talk had to do with these practices as a way of overcoming the side effects of cancer treatment and improving quality of life. But isn't there also a connection to actually helping to fight the cancer itself? In other words, don't these practices actually make us healthier in terms of our ability to overcome cancer and other diseases?
It's a tricky question.
Yeah, I know it is.
Yeah, that's a tricky question, and it's a tricky question for science and also medicine. And it's, I think indirectly, as I spoke about mind body medicines and their impact on the immune system, their beneficial impact on the immune system. Certainly, if there's a beneficial impact on the immune system where the immune system is working better, then we would hope to see better outcomes. But I guess we could say stay tuned, right?
Okay.
Yeah.
And I know we're out of time, but I have one final question for you. Yeah, I was shaking his head. Take more time, ask more questions. Okay.
And I have a question for you too.
Okay, well, so I know as a patient and somebody that talks to probably 50 patients a month, so many times I hear the story of, my doctor was great in terms of telling me that I needed surgery or that I should have radiation and here's the outcome and, this and that and the other thing. But at no point in this process was I offered, here are the mental health services that you might need to have, or I'm going to connect you with a dietitian or a physical therapist or a physical trainer or a financial counselor, all of these things that surround us as patients, but are not directly related to the immediate medical treatment that we receive. So how, as patients, can we advocate for ourselves to get these additional support services that are so important to our quality of life?
Yeah, that's a really good question, because here at Fred Hutch and in many institutions nationally, these institutions are offering integrated medicine services. But the patient has to know that they exist, and they have to know what they are.
Right.
So I think as time goes on, as we do a better job at letting patients know that the services are there, they'll be able to ask for them. Instead of, because actually, I think probably in patients' packets, there is some information about integrated medicine, but that's not the first thing that people are looking for or waiting for. So I think we can do a better job, and hopefully we will be doing a better job.
And when you get the SCQ, and you get the SCQ supportive care questionnaire, don't ignore it, because your answers to that actually filter to us, and then I order consults for people to see nutrition based off of that. And I know there are questions about Dr. Price's discipline and all of our disciplines at UW and Fred Hutch. So if you get that SCQ, fill it out.
Thank you, Ray.
Could I just tag on to that? I think, the answer is in some ways self-evident. Reflection of the training of the practitioners and what that training does not include.
Yeah. Yeah, a lot of feelings, but I want to, it's about our panelists. So, I'm going to keep my thoughts to myself, other than say I'm happy to share patients with Dr. Price and many of our supportive services. One of the things that really at Fred Hutch differentiates us, I think, from many other providers in that region is that we really have all of these supportive services for cancer patients, right? We don't think about the cancer patient as just needing a therapy. We think about the whole patient. And so there are a lot of services, but I also think it's complicated, so Marty, you have your hand up.
Just going to say if Dr. Price has a question.
She does, and she should ask. But while she's asking, can we bring all of our previous speakers and Oprah's interviewers? Dr. Phil? No, he's not good. All right. We'll find somebody else.
Marty, my question to you is that mind, body practices, lifestyle modifications, all these things take time and effort, and in consistency. Someone talked about consistency. Was it you, Ray? And so how can we compliance? That's oftentimes we're used to taking a pill, and that's what we do, is we take a pill rather than modifying our diets or getting that consistent exercise in. So how can we help to advocate compliance for our patients with regards to integrative medicine?
Boy, that is such a good question. I'm fortunate in that I'm retired. So I make it a priority to spend an hour to 2 hours every day exercising, whether that's at the gym or out running or whatever it is that I'm doing. But I realize that's not possible for people who are working full time and so on. It's challenging. What I tell the guys in my support group is, first of all, exercise is extremely important. It's more important than, statistically, studies have shown that it is better for you than a lot of the medications that we take or some of the other interventions. So if it's a priority, make time for it, but find something that's fun. I'm a runner. I've been a runner all my life. I don't run as far as I used to because I'm old, but I still do it because I enjoy it. But guys tell me, well, I couldn't do that. I hate running. Well, then don't do it. Don't make that your practice. Find something that you enjoy and then make time in your life to do it. And if it's, an hour a day, great. If it's an hour a week, that's still better than sitting on the couch for that 1 hour a week. So do what you can. Don't set the bar here if what's reasonable is here. Set it at something reasonable and then make it a priority and do it. That's not a great answer, but it's all I can say.
Good answer, Marty. All right, you guys know the drill. If you have index cards, hand them in. I guess my question would be to Ken to start. Kenny. In my practice, especially when I sense that men are having issues emotionally with their diagnosis, it's not uncommon for me to recommend that I put in a referral for mental health. And oftentimes I get no, I'm all right. No, I'm good. Where are we failing when we're engaging in those kinds of conversations and helping people connect the dots that we do and we can help support them?
I believe some people spoke earlier about men kind of holding their feelings close to their vest. I'm a big proponent of support groups. So maybe if there's a way to get men to a support group where they're surrounded by other men, or, it could be men and women, but put them in an environment where they see other people being comfortable expressing themselves. Maybe they'll take that opportunity to open up. I don't know what that feels like to not be able to express oneself, but I know it's out there. So it's a real thing. And yeah, I'm a big fan of support groups.
Yeah. That's one thing that, thanks to Marty, I have a printed out sheet that I can hand to the guys. And I feel like sometimes when they come in for their second visit, they're open to send those other things. So the support groups are really powerful. Chris, any additional tips to both the patients in the room, caregivers, and providers on how we can better utilize the services your team provides?
Yeah, I think, definitely the support groups, being open about your experience and what you're going through. And when I talk to patients, how I sort of phrase it is, you sort of think of mental health services here at Fred Hutch as sort of like let's imagine you're building a house, right? You could build a house with your hands if you really wanted to, right? But if you have a hammer, why wouldn't you use a hammer, right? You could go through this entire experience on your own, and I'm sure a lot of people just white knuckle it. You're just hand on the rail, just making through it. But if these support services are there to help you get through it, and hey, they're there when you need it, and when you don't, then you don't. But if it makes that much easier to get through your day to day and have that life that is, where you're not feeling like you're withdrawing from the things that are important. I think having that conversation is important.
All right. You want to add on to that?
I would just add, in some of my research for some of these talks that I've given, I found a number of apps that are focused on the mental health care of cancer survivors, and there are a few that are really focused specifically on prostate cancer survivorship. So that really puts mental health care in the palm of your hand, and it can be private, it can be, you don't need to necessarily sit with someone face to face. So if you're feeling like that is too much of a reach for where you are, maybe consider some of these apps that have been shown to be really helpful.
If Dr. Hehemann shares those apps with us, we will send it to all attendees. Dr. Hehemann, since you're already speaking, we'll go back to you. Taking Cialis and Viagra together, is that daily for a short period of time, post-therapy, or as needed? I'm asking for me as a provider prescribing too, am I allowed to do that now?
Yeah, so just to kind of go back to Viagra is sildenafil, Cialis is tadalafil. These are medications that act in the same way. Their mechanism of action is pretty much the same. They just have a little bit of a different profile in terms of when they start to be active in the body and how long they last. They are, by and large, very safe medications. There's only really one major contraindication, meaning, you shouldn't take it if you do this, which is you also take medications for pain in the chest, like nitroglycerin. That's the main thing that you need to be, safe with not taking Viagra type of medications. They can be combined. So there are many patients in whom I prescribe both of them just because of that difference of when they start to work in the body, where tadalafil can last all day and you can just take it on a daily basis, where sildenafil has a little bit of a shorter window, so it can be taken more on demand, and absolutely safe to take them in combination. Usually I give patients instructions on how to not go over the limit, but even if a slightly over the limit, it shouldn't really pose a major health risk. And in terms of longevity, it's, it kind of depends on the guy. That's why I see patients regularly after their treatment, just to check in on what's working and, if there are side effects and whether we need to explore other avenues.
So thank you for that. And this has been a changer for us, and we probably need to actually update our rehabilitation program, but I've started to do it more as a result of my partnership with Dr. Hehemann as far as doing that combination, which I think a lot of guys like, anecdotally. I was asked several questions on the cards about what supportive services exist at Fred Hutch. This is a website. As you can see here, most of the people that are on the panel are represented in some form here with all the different services that we have. And it's pretty extensive, and I find that patients often don't know that we have all of these different programs available to support. So we'll share this link with people attending, but I wanted to just show you that if you search Fred Hutch supportive care services, you can find all the different things we supply that are adjuncts to just like the therapeutic care that we provide as well. All right. So many diets. So a good question on diet. How do we overcome the need for protein, perhaps when you're on ADT, androgen deprivation therapy, with some of the recommendations around plant-based whole food diets? Do you have any go-to ways to get protein in on a regimen like that?
Yeah, so good to note. I mean, the prevailing thought is always protein, you have to eat meat, but there is a wide array of plant-based foods that are protein rich, including beans, lentils, nuts, legumes, soy products. Certain whole grain foods are kind of medium protein, but in a good combination diet, it can all add up well. Also, too, when we have this concept of plant-based eating, from the dietitian's perspective, that does not automatically equal that it is a vegan diet of only plant basis. And the overall metric that we're generally looking for anyone at risk or affected by cancer is to make their diet be at least 2/3 in total plant foods, 1/3 or less from animal foods. So I've even had some folks that are pretty close to the vegan side, but again, with ADT, so I don't know if all of y'all have heard this before, but through research, we've seen some of us on ADT will need as low as only 1,400 calories per day. And above that, we could be unintentionally gaining weight. So I've got some folks that are pretty close to a vegan diet, but then with maybe 25, 30 grams of whey protein powder that you can just mix into a shake where you're putting in some of the greens that maybe I know I need these, but I don't love the taste. And then you throw a handful of blueberries over top and it all looks purple and tastes great. And that can be a way to sneak in that little extra protein boost you need. Androgen deprivation therapy, so Medicaid like Lupron injections and all the other things under that category that take away your testosterone, and so we need that extra protein to kind of combat that effect. Thank you.
Several questions that were kind of answered about with the supportive care website, but question about supportive services for caregivers, spiritual care, and naturopaths. And I know we have all of those services available within our institution, but I don't know, Dr. Price, do you want to take this on? How do you think about providing or integrating some of these other pieces of care into a patient's support plan? Like I'm thinking with caregivers, maybe some of our social work, depending on what their needs are, or navigation services could be helpful in that setting.
Yeah, so I'm not actually sure how to answer the question, but I'm going to send it down to you.
Sure. So in psychiatry, we work pretty hand in hand with social work. So most of our social workers practice at the top of their license. So they're what we call licensed clinical social workers. So they're able to provide supportive therapy. They're often the first line people that you'll meet and talk to. And they'll be like, hey, do you think you want to talk to psychiatry, and have that question with you? By that same measure, we do have spiritual services where you'll talk to somebody who, if that's more your inclination to look at it from that perspective, that they can provide that same kind of supportive therapy as well. So, part of it is I had one patient I remember talking to, they sort of printed out the website like it was a brochure and just checked each one they talked to and make sure they touch base. So, yeah, it's opening that door, and if you need it, you need it. If you don't, you don't. But yeah, it's there for you.
And then I had one question online, which was around PT, physical therapy after surgery. Why isn't it standard? And I was just going to answer that quickly because we're at time. But a lot of that just has to do with the lack of available physical therapists, number one. So they're in really high demand and short supply. And number two, not everyone's going to need them. So a lot of patients are going to have a really normal recovery. Now that may take some time, and PT might shorten that. But we tried to start with kind of the self-directed Kegel exercises and really reserve what is unfortunately a limited resource for patients who are still having issues after surgery. So with that, I want to give a warm or a generous round of applause to this group on covering the topic.
Okay.
I'm fading a little bit, mincing my words here, but such an important topic, and I thank everyone for making the time again on Saturday. We don't have a scheduled break, but if you need to step out to use the restroom or anything like that, please do. We have our final session. Got two of my favorite medical oncologists. I'm not just saying that because they said yes to showing up today, but they are newer additions to our program who bring a lot of positive energy and new thoughts to medical oncology. So We're gonna start with Ruben Chowdhury and Bing again. Ruben is an assistant professor in our medical oncology program. He helps support both him and Dr. Khan support our multidisciplinary prostate cancer program, in addition to seeing patients in their medical oncology practices. So Ruben, come on down. You and Hiba have seen how this goes with interview style. And do you have slides for me to pull up? Okay. All right. So here's the mic, hot mic number 1. You've got one in a seat. All right. Ready? Ready. Or dark. Yeah, let me go ahead and close this. All right.
Okay, doctor, thank you. This is the topic that none of us want to talk about. This is metastatic prostate cancer. And really, I think it's one of those things where those of us that have dealt with it or been through it, it sounds scary when you begin, but it's there. I have to say that from my experience and my journey, there are a lot of options out there. They're not all fun, but there are options. And I think it was mentioned in the last group is that you really have to approach this with hope. You know, you can just believe you can get through this if you work with your physicians. And, you know, that's just kind of where we are. Do you want to give us some quick stats on what we're seeing as far as metastatic disease? I know prostate cancer is sort of on the rise. And I know the American Cancer Society numbers just came out, or they've released them again this year. So can you give us an idea about what's going on, or why is it rising?
Yeah, thanks. Thanks for having me, and thanks for organizing this. It's great to be here. So, yeah, metastatic prostate cancer, it's what everybody's trying to avoid. That's the whole goal of prostate cancer screening, is to provide early treatment to prevent the development of metastatic prostate cancer. However, when metastatic prostate cancer does arise, there's a large spectrum of what that disease looks like. And for some people coming to my clinic with a large burden of metastatic disease, a lot of different spots on scans, coming in with pain, that looks a lot different than somebody who comes in, had surgery 10 years ago, their PSA is starting to rise, and you see maybe 1 or 2 spots on just one of our very high resolution scans. So first of all, I just want to say that not all metastatic prostate cancer is the same. Second, there's been a lot of improvements in the management of prostate cancer, metastatic prostate cancer. And for a lot of people, we think about it as more of a chronic condition that people live with. And the average survival with new treatments is around 5 years. And some people can live a lot longer than that. And of course, for some people with very aggressive prostate cancer, sometimes with some genetic alterations that we see in the DNA, that can be shorter. But on average, people are living for years with prostate cancer, and that makes all the supportive care topics that we discussed, nutrition, fitness, mental health, all of these things are so critical because, again, people are living with this condition for longer and longer now. In terms of why is metastatic prostate cancer on the rise? Well, it's not entirely clear. I think one of the some statistical evidence suggests that this corresponded with a decrease in PSA screening, where previously the recommendation had shifted that PSA screening wasn't improving survival. And then once PSA screening declined, it looked like that's when the rate of development of metastatic prostate cancer started to increase. There's certainly dietary and sort of lifestyle considerations that are probably at play. There's a couple of sort of interesting lines of evidence that play to that. For instance, where there's some interesting sort of twin studies that have looked at people who immigrate to the United States or Western countries often have a higher rate of prostate cancer compared to their siblings in the country of origin. So, you know, there's still a lot to be learned about that. There's certainly in terms of, you know, lifestyle and yeah.
So when you it's determined that you're metastatic, there's so many options, right? There's hormone therapy, chemotherapy, radiation, theranostics, and hundreds of clinical trials that are out there. How do you have those discussions? I mean, you don't have time enough in the day to eat and practice. So how do you have those discussions with patients and about what should their course be? Obviously, prostate cancer is different in everybody. But what do you recommend, or how do you go through that discussion with patients?
Yeah, absolutely. So I think everybody's prostate cancer is different and everybody is different. Everybody has different goals and preferences. And so I think, understanding what somebody's goals of treatments are is the most important thing. So some people, their focus is longevity, especially. So they want to do whatever they can to live as long as possible. And some people's focus is minimizing side effects of their treatment. And obviously, most people are somewhere in between. And so we have to discuss, what do we want to do to, so for instance, when I see somebody with newly diagnosed metastatic prostate cancer, hormone therapy is considered generally the backbone of treatment. But, there's discussions about what the best way to implement hormonal therapy are. And today there's actually a lot of different ways that we can implement testosterone lowering therapies, and they have different side effects and side effect profiles. With regards to longevity versus toxicity, we think about, for instance, should we start off with chemotherapy in the first line treatment setting? And that's an area of great controversy. It's obviously associated with a lot of side effects. Giving real chemotherapy, we think about like hair falling out, diarrhea, nausea, all these sorts of things. And so that's another important consideration as to whether or not we want to start off with sort of aggressive treatment.
Yeah, so that leads us into advocating for yourself a little bit. This is when you're doing treatment for metastatic disease, it gets pretty serious, and you need to, what are some of the conditions like heart disease or dental issues, bone density, blood pressures, all those things that are compounding morbidities for each patient? Please explain to us why it's so important that you as a patient explain to your oncologist that what's going on with you, because they just may not know.
Yeah, absolutely. It's a critical consideration. And especially this goes into with metastatic prostate cancer, people are living for years now. And so some people may die of causes even with metastatic prostate cancer other than the prostate cancer. And so we really need to look at the whole patient. Somebody has heart disease, they're older and frail, risk for fracture. All these things need to be taken into consideration. So for instance, I think some of the neglected things are dental care. If somebody comes in to start chemotherapy, we've seen this where somebody hasn't taken care of their mouth their whole life, and they get chemotherapy and they develop an infection in their mouth. We often start medications to improve people's bone health, to decrease the risk of a fracture, which can happen because hormonal therapy causes your bones to get weaker over time. And prostate cancer often goes to the bone. So it's a double whammy there for developing fractures. And so a lot of our medications to build up bone strength also carry risk of developing jaw disease. And so really important to have to get regular dental care before going through this treatment. And then the other is heart disease, blood pressure issues, risk of strokes. All of these things can happen with long-term use of hormonal therapy. And so making sure that your nutrition is on point, you're exercising. I think resistance training is one of the most important things that you can do with prostate cancer. It maintains muscle mass and it decreases fat mass, and all those things are really important for decreasing the side effects of hormonal therapy and ultimately making you a healthier individual.
Yeah, I'll mention just there's a book out. It's in its third edition called Life on ADT, and it comes from Vancouver or BC, University of BC, and a guy by the name of Richard Wassersug and Lauren Walker are the physicians that put this together. And it's been studied quite a bit, and there's all sorts of recommendations in the book. It's about 100 pages long. It's easy on how to mitigate those side effects. And I was referred to that in my care, and it worked. I can attest to the fact that if you do some of the recommendations, like you just said, the resistance training, walking, a lot of the exercise stuff every day, it makes a big difference. And then there's some things that you don't want to eat when you're on chemotherapies and other things that you would think would be, good vegetables, but they don't react really well with the chemo that's inside there. So that, and what are you seeing as far as medication adherence? I mean, is it, because it's critical when you're on this treatment. I mean, from a patient perspective, some days you just don't want to take the med. But I know that, medication adherence is a big issue. And are you seeing patients doing a better job of that, or is it still kind of a challenge sometimes?
It's hard to know. People don't often tell me if they're not taking their medications. But it's yeah, it's challenging. I think about this, myself a lot. So there's one of the two main ways to lower your testosterone is one is an injection called Lupron, or there's other sort of drugs like that. And there's a pill that you take every day called Orgovix. And I sometimes think, man, it would be really hard to take a pill that would make me kind of feel crummy every day. So I talk to people about that. It's this psychological burden that you have to take this thing, and it's going to make me not feel great every day. Especially if you're not having symptoms from the prostate cancer, right? So you come into the clinic, all you're seeing is a PSA is high, and there's some spots on your scan, and we're telling you to, take a drug that makes you not feel like yourself. That's really hard. So I think it depends a little bit on, I think probably adherence is much higher if you're obviously coming into clinic to get an injection, or two, if you're having if you develop symptoms from your prostate cancer rather than, just seeing numbers and scans.
Yeah. It is a challenge. Again, having done that, there are days you don't want to take it, but when your wife's standing there staring you in the eyeball, you end up taking it. So it's one of those things, when they start doing the doublet and triplet therapies and things like that, it can get pretty complex. And then you're going through this cognitive decline when they put you on these medications. You really don't, they ask you to fill out quality of life, brochures or whatever. You can't remember your name, much less your quality of life. So it's a bit of a challenge, but it's doable. If I can do it, anybody can do it. And so it's just those things that you just got to really go to, like some of the paper methods, I think, and some of the calendar methods and stuff like that to really, get serious about it and watch out for yourself and advocate, get your family involved as well and talk about what you're going through.
Maybe one more question.
Yeah, sure. So what do you think? What do you wish that patients knew more about in sort of determining their sort of first line of treatment for metastatic prostate cancer?
I think one is where to find good resources as far as educating yourself. So that when you come into your appointments to talk to the oncologist, right? First of all, you're not scared because you're an oncologist. Secondly, which is anxiety is an issue. The other is that discussion about what's going to happen. I mean, we know what the side effects today are. I mean, these physicians all know what the side effects are going to be. And I think, though, if you have that discussion about what can I do about these things? I know I'm going to go through this. What if I knew what some of the answers were? It would be much more, I think, more beneficial discussion to have in your office, right? So I think it's trying to prepare the guy for the treatment, not just give him the treatment, right? And I mean, I know I was lucky enough to have I still do have a great oncologist, and that was one of his big deals is that, okay, we're going to sit here for an hour and we're going to talk about this. And it's going to be something that, take notes and you need to remember, and, we're here and we're available. But I think it's just that education. I wish I'd have known what the side effects were going to be before I started. I kind of find out afterwards, but I would say that's a hard discussion because you tell somebody these side effects and you don't, you're sitting there thinking, geez, do I really want to do this? And, you do. I don't trust you. You do. Trust me on that one. They can be bad, but they're not going to always be that bad. Okay. The alternative is a lot worse, put it that way.
All right.
Okay.
That was great. I know we're generating questions. Thank you both for your candor and your time. I think in the metastatic setting, choosing the treatment is the first really tough decision you have to make. And then the second one is how do you deal with the side effects? So we have Dr. Hehemann, who's also an assistant professor in the Department of Medicine, Hematology, Oncology, Fred Hutch. I mean, am I missing any titles, you two? Also, prostate cancer specialist in our group. So thank you for your time. And I know David Anthony has some questions for you.
It's been a long day. I hope everybody's gotten up, take a little stretch. When I used to teach, even in my exam, in the middle of the exam, I got everybody up for a minute. So don't forget that. Don't forget the legs. I have a couple of questions to pose, but I also want to share something that I discovered yesterday. It's called Exercise Recommendations for Prostate Cancer. It is on the page from Fred Hutch Institute. Have you seen this? Have you seen this? Take a look. Take a look. Okay, so I couldn't listen to this exercise, you know. I don't know if you can do it from my iPad.
Look, Dante's an author on here. Dante,
Okay.
stand up, take a bow.
It's like 24 pages, babies. I'm telling you. Okay.
This was a great study. Lauren Brady is in the lab with Pete Nelson, and BACPAC contributed patients to this work. So this is great. Thank you for sharing.
So I want to preface this or start with a question, and I'm sorry if I'm stumbling, but it's like the last 6 years of my life have been profound, okay? In terms of my transformation. My diagnosis that came, I said earlier, it was around 2016, was followed by a long period of grieving of the loss of my mother. And I realized that I was experiencing extreme depression to the point where I didn't want to live anymore. And I think that extreme grief situation contributed to my disease. I haven't talked to a lot of people about this, but I think it's a reality because when you look at prostate cancer, you are looking at a holistic situation. Your cancer does not exist in any kind of compartment. It is part and parcel of your entire life. So everything that I have done in the period when I decided that I wanted to live was to affirm that and to work as hard as I possibly could to be worthy of remaining on this planet and succeeding my parents in life. So my first question is, what can be done about managing and mitigating the side effects of ADT hormonal therapy?
Thank you for sharing that. And I'm very happy to be here. Thanks for asking me. So I see a lot of, like Dr. Ray Chaudhry, I see a lot of patients in my clinic on hormone therapy. And for just a quick refresher on what hormone therapy actually is, we've mentioned ADT, hormone therapy. It's a therapy that can be delivered in a number of different ways with the goal of reducing the testosterone in your body. We know that testosterone drives prostate cancer growth and spread. And in early states of prostate cancer, the number one strategy we use to help treat prostate cancer is by removing all that testosterone. So to me, I spend a lot of time in my clinic talking to my patients about the mechanisms of why they're going to feel the way they feel, so they have some understanding when they have some symptoms, when they're experiencing symptoms. Okay, why is this happening? It's because my testosterone is low, and then we can talk about ways to mitigate side effects. A lot of those side effects, mitigation strategies were mentioned mentioned already, things like exercise is incredibly important. Dr. Ray Chaudhry mentioned resistance training, one of the best things that you can do on hormone therapy. It helps strengthen the bones, helps strengthen the muscle. A major side effect is muscle loss and bone loss, and so that helps with those. Hot flashes, I'm sure a lot of people on hormone therapy have experienced, and often we'll talk to the men in the room and we'll talk about side effects, and I'll mention hot flashes, and I see out of the corner of my eye there's spouse or significant other or somebody kind of laughing about experiencing hot flashes together. But there's lots of mitigation strategies for hot flashes as well. Things like returning the hormones for men, things like using progesterone or estrogen patches. So I'll stop there, but there's a lot that can be done.
Okay. I know all of this stuff that, I mean, I'm the guinea pig. Because I had the hot flashes and the fatigue and the joint and muscle weakness and other things I can't even talk about. Now, my response was to assiduously work with physical trainers, to double down on martial arts. I do Tai Chi, Qigong. I have a whole history of that goes back to when I was about 19. I've been on a plant-based diet since before I was diagnosed, and I'm still on it. I do still eat fish, but generally speaking, I've cut way back on dairy, and I don't do any other animals, anything with a face except for fish. But I found myself, I have a close friend who is an Ayurveda specialist, and I've worked with her. I've done yoga. I've worked on diet and nutrition and all kinds of exercise. So without going back into that, let me just say I have another question, which is, in spite of how much we know and how many diagnostic tools we now have to recognize and to treat prostate cancer, the people most at risk are still in the main either unreachable or subject to the vicissitudes of a health system that is largely unmoved by the urgency of their therapeutic needs. What can we do to help change that?
Yeah, you asked me the million-dollar question. I think that what we're doing here today is an excellent example. So being in people like yourselves, who know what it's like to have prostate cancer and know others in the community, in your families also with prostate cancer. I think one of the things that I hear a lot in my clinic is, and I know there was a session on genetics this morning, but oftentimes I'll ask about family history and I'll hear, my dad had it, my uncle had it, my grandfather had it. So for a lot of people, they said, yeah, it's just a matter of when and not if, right? So my answer to that question is spread the word, talk about prostate cancer, talk about the fact that there are effective treatments for it if caught early. I think what's happened with PSA testing in this country is a travesty. Because we are seeing rises of deathly and metastatic cancers that could have been cured if we had talked about it. So I kind of, we do our part. We educate patients, and we of course see patients in our clinic, but spread the word and talk about your experiences. I think that will help.
I wanted to say on the back of that in that year after my mother died, I lost 90 pounds. 90 pounds in 1 year. So basically, since I have gone off of ADT, with the help of my hematological oncologist, she said to me, you got to rebuild your body. And that's what I've been doing. That's what I've been working at. And my fantasy now is to become a ninja.
David, I have bad news for you. Can you stand up for us, sir? You are not sneaking up on anybody. All right. Ray, could you come down? We'll do a Q&A. David, you can stay seated, please. Bing. I have one question, Carl. I've been holding on to it because it's such a good question. I'm going to read it verbatim, which I haven't been doing. But it says, many comments are about patients educating themselves. And providers don't have the lived experience of illness. How can the Fred Hutch system better inform providers on patient needs? Now, I think it's a good bookend to where we started with Paul Buckley this morning, right? We need to hear from you. So one of the reasons I really love this forum is it gives us an opportunity to learn. I have a lot of unanswered cards. There was one about the VA biopsy experience. I sent that to my boss, right? I didn't answer it directly, but I sent it to him to say that we need to talk about this if someone feels like that experience isn't congruent with what we said it should be. So we're gathering information today as well, right? We're sharing hopefully a lot of knowledge, but we're also taking in a lot of knowledge. So with that, I'm going to transition to our Q&A. I do have a question about from a patient here who's looking for longevity and not a cure. And the question was about how does heterogeneity of tumor affects Pluvicto treatment success? And I would actually argue just treatment success in general in the metastatic setting. And then maybe how do we define, what does it mean for heterogeneity, like in simple terms? Because I'm a urologist.
Yeah, that's a great question. So heterogeneity, so we're talking about cell surface targeted treatments. And so when we think about heterogeneity, not all of the prostate cancer cells are this.
Cell surface targeted treatment.
Yeah, sorry.
Yeah, let's go ahead and break that down.
So you can think, sorry, to back up. So prostate cancer, it comes from a cell in your prostate, right? And that cell then moves to different parts of your body. And over time, these cells develop different adaptations. And so if you look at doing a biopsy from one piece of your body, and then you look at a cancer cell at a different part of your body, those cells might not be the exact same thing. And that has implications for treatment, especially treatments that are targeting what's called cell surface proteins. And so on our cells, we have little markers on them, or like flags. And one of those flags is a protein or a molecule that's called prostate specific membrane antigen, or PSMA. And this drug Pluvicto basically delivers radiation to any part of the body that has this PSMA on it. And so if you have one of the cells in your body has this PSMA, but a different side of the cancer does not have this PSMA, then only one of the parts of your body will respond to this treatment. And so there's a couple of different ways that we're thinking about how to manage this. And one is using a PET scan. So the PET scan basically lights up everywhere in the body that has this PSMA there. And so if somebody has their PET scan, it shows bright disease everywhere in the body, then we think this is probably a treatment that's going to be effective. If we're seeing a lot of spotty, so one of the cancer spots has really high amounts of PSMA, but another one doesn't, then we're thinking about other options. So what are the other options? Well, one, are there drugs that can be used to increase PSMA levels? Two, what if it's just we need to give a higher dose of this drug? And so we can think about actually giving more, because usually it's not 0 PSMA, or it's usually like, if we're just like from a scale of 1 to 100, it may be 5 in one spot, and maybe we just need to give more of the drug. Or 2 or 3 rather, we give combinations of drugs. So for instance, one spot may have a different protein on it. For instance, I'll just say like protein X, and then we may want to give a drug that targets both protein X and PSMA together. And so that sort of covers your bases in terms of the heterogeneity question.
I'll add that this is an active research question of Dr. Ray Chaudhry's. He has several studies in this field. So whoever is interested in the heterogeneity question, I think enrolling in a clinical trial is always a good thing to do.
All right. Same patient had a couple of questions, but one, the very last one said, turkey tails question mark, feeling desperate. And just, I think coming out of a session where we're talking about integrative medicine, how do we navigate in this particular space the different information that's out there of alternative things that might not be in the New England Journal or Lancet that you still may feel like it's worth a try if there's benefit?
I'll tell you my strategy of kind of integrative or supportive treatments that don't have evidence. Like Dr. Nyame mentioned, it's incredibly hard to do these studies. There's not a lot of enthusiasm from the folks who typically support our research, large pharmaceutical companies, et cetera, to study things like supplements. And so that means that we are all left with a lack of good quality data. If somebody approaches me and wishes to take something like turkey tail, or I've seen some other supplements, zinc I've heard of, my approach is to just say, whatever you feel like you want to take is okay with me, as long as it does not interfere with any of the treatments that we're doing together. And if they are, then we can talk about them. I have our pharmacist review all of the supplements and tell us if there's any interactions with any of the hormone therapies or oral medications, chemotherapies, et cetera. So that's kind of typically my approach. But I also suffer from the lack of good quality data and evidence that there is.
I just want to add one thing because I saw some whispering. Turkey tail is not the tail of a turkey. It's like a mushroom.
I think one of the most important things that was said, though, is if you're going to do one of these things, like high dose vitamin C or these other things that are out there, please know that you got to talk to your physicians. You got to talk to the oncologist, because there are studies, there are papers out there that can show interference in what they're trying to do. And you're also just putting yourself at risk if you get into that kind of a mess. And, you know, the other is clinical trials. I would ask, how many, I don't know if any of you have considered clinical trials. I highly recommend them because you get better care and they're always watching you, poking and prodding. But there are very few clinical trials. I mean, we even had a discussion about the word trial. It's not a trial. You're being studied is what's going on. They're studying or developing. And by the time you're typically in a trial, it's pretty well proven. They're just sort of gathering data around that specific treatment or option.
Yeah, we had a working group on metastatic prostate cancer in Atlanta with the American Cancer Society. And, you know, one of the things that we talked about is that if you're enrolled in a clinical protocol, clinical study, clinical trial, whatever you want to call it, that you typically live much longer, like significant amount longer than if you're not. So, we were talking about clinical studies are a form of really high quality care too, right? They're not experimentation, right? The burden to get these studies approved is quite high, of proving safety and then some level of efficacy. So,
and as a patient, please ask your physician on what's available, because they'll know your condition. They'll also know. Don't go to clinicaltrials.gov. You'll just get frustrated and get lost. Okay, don't. There's a lot of other tools out there. Obviously we can help try to find those for you if you'd like, but I would always speak with your physician, urologist, or the oncologist and ask them what's available, what's out there.
All right. One more question. Are there effective treatments for aggressive prostate cancer that is confined to the prostate? You guys don't want to take that on?
Yeah, sure. I'll take it on. Speaking as a non-urologist and a non-radiation oncologist. So Dr. Nyame mentioned our multidisciplinary clinic here. So I would say one really effective strategy is teamwork. I would encourage, all of you, wherever you're getting your care, to see, if you're thinking about treatment for localized prostate cancer that's non-metastatic, talk to a radiation oncologist, also talk to a urologist, also talk to a medical oncologist, because you might find something in those multiple conversations that you feel like fits more with your sense of where you want it. Like Dr. Rachel mentioned, everybody has a little bit of a different goal about what they're trying to accomplish in their prostate cancer care. The more people you talk to, I feel like the more, and I don't mean, see 7 different medical oncologists, but you know what I'm trying to say. The other thing I would say is that this is an area of active study. So we are doing multiple studies here also at Fred Hutch, where we are trying to answer this very question. We know that there are aggressive features of localized prostate cancers that we know have higher risk of becoming metastatic disease, that we know we're not going to be that successful at curing them. And this is a great role for clinical trials. We have a couple here, so I would encourage all of you guys, if you're interested in prostate cancer, localized treatment and more aggressive prostate cancer, that's a good place to start.
The only other thing I'll mention is that for most people with localized prostate cancer, treatment is urgent, but it's not usually emergent, okay? And so it's really valuable, I think, to seek a second opinion and just make sure that you feel comfortable with your decision. And, it's not like a high pressure sales situation. It's, really take your time and meet with folks, meet with other people who've gone through this. The support groups are a great way, I think, for people to sort of get more information and don't delay too much, but you don't feel that you have to rush, even if it is an aggressive, high grade type of prostate cancer.
All right. And I'll finish answering that question too, as someone who treats localized high-risk prostate cancer. I mean, one of the true advantages of our program is our multidisciplinary clinic, because I find that this is a curable cancer. Cure rates are probably somewhere around 85 to 90% in the long term, but it tends to be a multidisciplinary treatment, meaning, just by being high risk, if you have surgery or radiation, your recurrence rate after treatment is about 50%. And that's the low end of that number. It can be higher if there are more high-risk features in your cancer. So part of what I think is really great about that clinic is you meet kind of the team that's going to be taking care of you in this long-term period, and you get introduced to the various different things that you may need. But there's still a lot that we need to study about managing high-risk patients, including how toxic is our treatment that we give for that success, and how do we meet patients' goals when they meet us? And I think we have good conversations around that. But this is definitely one of the more complicated areas, because if I was to poll in the room who has the most severe post-treatment side effects after surgery, it's going to be someone who had surgery and then needed some radiation and some ADT, and it's kind of like compounding interest of all the different things you get. So with that, I just want to thank this panel. The final group, a round of applause for them. All right. Again, I want to thank our sponsors and supporters: Intuitive, Boston Scientific, the Institute of Prostate Cancer Research, Johnson & Johnson, and Zero. A round of applause for them as well. I want to give a special shout out to Sungmin, Marielle. You guys have to wave your hands when I say your names. Marielle, John Masembe. All right. Liz Sage. Most people who work with BACPAC know them as BACPAC, because they're the ones who are answering the emails and supporting the team. So thank them. I want to thank them for all they do. And then Ritu and Meredith and the whole Fred Hutch team that supports AV and everything else. They make our jobs really easy. So I really want to extend a warm thank you to them as well. All right. Last but not least, I want to say a special thank you to you guys. I always get emotional, but it means so much to me that you guys are willing to be in community with us. Saturdays are sacred. There's a lot of good college football going on. Florida is beating Texas. Patrick, I don't know why I looked at you, but it's happening. I know you have a lot of things you could be doing on a Saturday. Spending it with us really means a lot to us. So thank you. Feedback is really critical. We've had 3 symposiums. All 3 have looked very different. We're still trying to find the right kind of setting, although I think this was a really good one this year, especially for who we have in the room. So please complete the survey. If you got your phone, take it out now. Take a quick snap of that QR code. I've been told the survey will only take like 2 to 3 minutes. Might take longer if you have a lot to say, but all right. Oh no, what have I done?